Well, hi, Physionic community. Welcome back to the Physionic podcast, which is my semi-annual, semi-inconsistent podcast that I release on particular topics that I find especially interesting that I've covered over the last, it's usually about every 6 months or so. So if you're watching the video version of this, you might notice that I'm semi-outside as well. That's because currently I'm taking care of my mother who had surgery. She's doing quite well. And I thought, it's such a beautiful day outside at the house that I might as well take an opportunity to record outside for once. So, what are we going to be covering in this episode, which will be surely several hours long, as they tend to be? I think, as I've mentioned last time, my record is, 5 hours, and I think I've got only about 5 hours of recording on my actual webcam, or on my camcorder, so it won't be lasting longer than 5 hours, I can tell you that much. So the topics that we'll be covering in this episode are Berberine as an anti-colorectal cancer supplement, 5 tests to ascertain your health and to achieve better health, try to improve those 5 tests. Then we'll be getting into restricting glycine that led to the reversal of cancer. I'll be getting into my favorite anti-aging hack, which will be highly relevant to being outside, if you haven't seen that analysis. I'll be covering my Lithium Revisited, which actually was not a very popular topic, but it garnered a significant blowback on me, so I wanted to cover some of the comments that were thrown my direction, as well as obviously the overall analysis and the results and whatnot. Then I'll be going over vitamin K against cardiovascular disease. So that was another one of these analyses where I got a lot of pushback and some questions that I wanted to clarify as well. I've also picked out some the top comments under each one of those particular videos on YouTube so that I can address some of those as well. And then I'll just be doing a little bit of housekeeping. I'm going to leave it on a positive note where I discuss a little bit of an exchange that I have with Michael Johnson. So Michael, if you're, I don't know if you're watching this or listening to this, I'd like to kind of highlight our conversation, which I thought was rather lovely. So without further ado, I think we'll be ready to go. I've got my Jovio mug right here. I'm actually at the Jovio quote-unquote factory. So if you're not familiar with what Jovio is, it's my dad's mug that he invented. I'm not going to go into the whole spiel. If you want to check it out, I'll put a link in the description. But I'll be sipping on this throughout. All right, so let's get into Berberine as an anti-colorectal cancer. Actually, before I get on that, I've turned off as many ads as I possibly can. All these different media platforms, it depends on which media platform you're on, but they have their different advertisement systems. Sometimes it's fully automatic, so I can't do anything. For YouTube, I have some control, not complete control, so I've turned off as many ads as possible so that you're hopefully not going to have an interrupted sleeping experience. That said, I think that's all I wanted to. Oh, you can also skip. I've got, I know that these episodes are super long. I will supply timestamps so you can skip to each section that you're interested in. But also, honestly, if you want the most in-depth, then just check out the actual analyses, which are posted on YouTube. I've got them on LinkedIn. I've got them on, I've actually started posting on Instagram. I'll talk about that a little bit later on. And my free public community, I also upload all the articles and videos there as well. So if you want access to everything, you can literally just type in the topic. So in this case, we're going to be talking about Berberine and colorectal cancer, and it should pop up in my public community or my email list. If you're part of my email list, again, that's also free. Then you also get everything just delivered to you. Okay. That's it. That's enough of a spiel. Let's get into it. Okay, Berberine, anti-colorectal cancer. So I ran across this study that came out in Cell, I don't know if it was Cell Metabolism. I don't think that it was, but some sort of cell adjacent journal. So some journal that is kind of a subcategory of Cell, if I remember correctly. Don't quote me on that. And within this study, which was a follow-up study, if I remember correctly, I think, yes, that part is correct. So it was a follow-up study of participants that had undergone a randomized controlled trial where the researchers had separated people to placebo group or to consume berberine. The amount of berberine, since I'll cut to that answer, is 600 milligrams, and it was split in two. I said it, I think, just like that, and for some reason a lot of people were confused. They thought they were asking if it was 600 milligrams twice. It is not. It's 600 milligrams, so 300 milligrams and 300 milligrams. And so this group took berberine for, I think, a year or two in the initial study. And then for this Cell follow-up study, what they did is they did a follow-up where 6 years later, they tracked if people still had reduced risk of colorectal cancer. And more specifically, they were looking at precancerous growths. So they were looking at things like adenomas or some sort of abnormal growth that was happening within the colon. And so they did that for the first 2 years in a randomized controlled trial setting. And then after that, it was no longer technically randomized controlled trial, but they did a follow-up for an additional 6 years to see if when people stop consuming berberine, do you still experience benefit? As in, do you still have reduced risk? Obviously, the way I'm talking, you should know that by now that in the randomized control trial, they showed that there was a reduction in neoplasms and adenomas. And these are kind of technical terms for abnormal growths that are kind of precancerous and are on their way to becoming cancerous, becoming colorectal cancer. So in the first 2 years, they found an effect. I think it was something like 20%. But then they had another outcome that they were interested in figuring out more aggressive forms of these adenomas and numbers of these adenomas. And both of those were also reduced. I think it was on the order of like 40-50% reduction compared, obviously this is relative to placebo. And then after the 6 years, I'm just going to repeat this one more time, 2 years on berberine, then they stopped consuming berberine, no longer on berberine. 6 years later, they still had reduced risk of these adenomas, these growths, these abnormal growths in the colon. So this is pretty exciting, right? Like that's a pretty astounding finding. Now, of course, there's always cautions with these studies, right? The study was very well done. I have nothing really negative to say about the study. The study was pretty large for a randomized controlled trial. Again, these things are pretty expensive, but even so, and I say this about other supplements and really just any study, when there's a single study that comes out, I'm extremely excited and I will report the data as it is, but there's always a want for some level of replication, right? I don't really want to have this assumption that it's going to carry continuously. So we're still waiting for some sort of replication. I say still waiting. I mean, it's been like 4 months since the study released. So it's probably going to be a few years before we have any sort of replication of this study, unless they're already working on something, which could certainly be the case. The same thing is true for like Glynac. When I covered glycine and N-acetylcysteine, those studies, all those studies come out of a single lab, right? They come out of a very reputable lab, Baylor Medicine research facility, which is great, but that doesn't mean that we wouldn't like to see other research groups come out, because the Glynac literature is just it's so impressive what they were able to pull off in older individuals. So the same thing applies to this berberine study, but I didn't want to leave it just there, right? I wanted to cover some of the mechanisms, like how is berberine having this effect? So I did find other studies by other research groups that look at the mechanistic relationship of berberine on colorectal cancer. So these are studies where the researchers are given, or not the researchers, the participants are given by the researchers berberine or a placebo, and generally they focus more not on like actual outcomes. So we're no longer interested in outcomes at this point, like as in clinical outcomes, I should say. They're more interested in the outcomes of like cell viability or cancer growth, like applying berberine to cancer cells that are taken from humans, or they apply it to mice that have colorectal cancer. Or are prone to colorectal cancer, and then doing a variety of different measurements. So when it came to the mechanisms, one of the mechanisms was a reduction in glucose uptake inside the cancer cells. So when you take these colorectal cancer cells and you apply berberine to them, and then you measure, for example, the amount of glucose that goes from outside of the cell, so the extracellular milieu, to the actual inside of the cell, you can measure that. And what they found is that when exposed to berberine, these cells took up much less glucose, and it was a concentration-dependent manner. So if the more berberine you added, then there was more and more reduction in the cancer cell's ability to take up glucose. So that's certainly one possibility. Now, of course, when you're looking at in vitro work, which means that you're looking at it with cells, like what I just described, actually applying berberine directly to the cells, the translation of that is very difficult. So there's always a little bit of wiggle room there, because yes, that could be a mechanism, but the amount of berberine that we're consuming is 600 milligrams. So does that translate to the level that's applied in vitro? Is that what's actually being delivered to the cancer cells? And often the answer is no, it's not going to be a direct one-to-one, but at least we know that berberine isn't just inert. It doesn't just do nothing to the cancer cells. It does have a direct impact, as in it reduces this glucose uptake. So sugar uptake is reduced. So that's one mechanism. The other mechanism, or another mechanism, is that it changes the microbiome to be less hospitable for colorectal cancer. So for this was in mouse experiments, if I remember correctly, where they applied berberine or a control substance to the mice. So they fed them a control substance, or basically regular chow, regular food, or the other group was given the chow plus berberine in addition. And they showed that, one, obviously colorectal cancer occurrence was lower in the berberine group, but in addition to that, they also showed that the microbiome changes, and they specifically pinned it on a particular bacterium. Now, I don't want you coming away thinking that it's only one bacteria. One bacteria is causing all colorectal cancer. It's not the case. Because of how strict the study design is, they only looked at some bacterium, and they just focused in on this one. That doesn't mean that there aren't many other factors that also contribute, but they showed that berberine reduces this one bacterium, and this one bacterium is linked to colorectal cancer. And they show, actually, I'm pretty sure this is correct, that when they exposed the mice that were predisposed, genetically predisposed to colorectal cancer, when they exposed them to this bacterium, that they developed colorectal cancer at a faster rate. So there is a link between this bacterium and, I don't remember the exact name. You'll have to go back to the analysis and all that stuff. I don't have that level of detail in my notes in front of me. But the big picture here, the big takeaway here, is that berberine has a direct impact on the cells, the colorectal cancer cells, and it also has an indirect effect on the colorectal cancer cells by essentially changing the environment of the colorectal cancer to be less hospitable to the colorectal cancer by modulating the microbiome, the gut microbiome. Okay, and then in the end, that leads to, as you apply more berberine to these colorectal cancer cells, their cell viability decreases, and it's kind of in a stepwise manner. So as you increase your berberine concentration, there's a reduction in the cells can't live. As in, it's not just that they don't take up as much glucose, but they also just can't survive. They undergo apoptosis, which means programmed cell death, which is a good thing, right? We want more of that when it comes to cancer cells. Okay, so let me take a step back here, because I always try to be as careful as I can be when communicating this stuff. This does not mean that you should megadose berberine. just need to pause there for a second, because people, which is understandable, right? You hear, oh, well, greater concentrations of berberine led to more cancer cell death, so therefore I will megadose berberine. But that's in an in vitro system. There are no consequences for that, right? You're just applying it to cells, and then you're seeing, do the cancer cells die? Yes, great. Now you apply it to an in vivo system, an animal, or to us humans, and I don't know, who knows? Maybe you grow a third eye, or like there's all kinds of different things that could happen. So it's not a immediate relationship where we jump on as much berberine as possible. The only tested dose is 600 milligrams split into 2 doses. Okay, just to be clear on that. Okay, so that's where I landed on berberine and its anti-colorectal cancer mechanisms. Now, there were a few comments. As I said, I pulled a few of the top comments. Some of them are kind of funny, like I think it's spelled or pronounced Sherry, Chyre. The auto captions say Berberine, as in like kind of like bourbon. I conclude that this means berberine and bourbon. Too bad my preference is Scotcherin. That's a good one. I got so many of different comments related to like the caption saying bourbon or berberine. I just don't have the resources to go through all my videos and just like correct all the captions. That just takes, it's beyond me. But it does make for some comedic relief regardless. So that was one comment. Then Mike Sins, MICSNZ, these largely come from YouTube, by the way. Is berberine only for colon cancer? What about other cancers? So that's a good question. The answer is, up to now, all that I've seen that's been of any convincing data, especially, having a through line between clinical data, mechanistic data, and maybe kind of in between of like associative data, although I didn't really look at that to much degree. The answer is it's only colorectal cancer up to now. Could there be improvements, in the future with other types of cancers? Absolutely. I'd like to see these data be reproduced, but I'd also like to see other types of cancers affected, or see if they're affected by berberine. And of course, with colorectal cancer, there's an advantage, right? Because colorectal cancer is right. Like when I was taught during my PhD, the way we were taught is that the body is, if you were to split the body into different sections and whatnot, the internal and the external section, quote unquote, of your body, the way to think about it is that your gastrointestinal system, the actual lumen, as in the opening of your gastrointestinal system from your mouth being open, like a tube down to your stomach, the stomach then to your small intestine to the large intestine, so on and so forth, and then back out your anus. That is all part of the exterior of your body. And the interior of the body is where you have this barrier between your blood system and this quote unquote exterior of the body, this tubing that makes up your gastrointestinal system. So the advantage of berberine is that you get a direct impact, and that's the same for like fiber, that's the same for really any nutrient that has colorectal cancer effects, is that we can directly attack those colorectal cancer cells because we're getting a direct exposure, or a very near direct exposure from the substance that we consume, if that's a drug or if that's fiber or if that's berberine, to the actual colorectal cancer. So it's much easier to target. And it wouldn't surprise me if we were able to just in general target those cancer cells much easier than we can other cancer cells. On the flip side, well, let me finish that thought. So on the difficulty is that then for others like breast cancer, that's inside the body, right? That, again, quote unquote, inside the body. I'm not saying, like, technically people could easily argue, okay, my gastrointestinal system, sure, the tubing might be quote unquote outside the body, but in reality, it's still affecting me, right? And that's a fair point. But the way it was taught, I'm just pointing that out. So if we go back to the inside of the body, it has to pass this epithelial layer, the actual gastrointestinal system, if you were to use a drug or berberine or whatever it might be, has to go into the bloodstream, has to travel the bloodstream and end up at the site of cancer. So if you're talking about breast cancer, brain cancer is even more difficult because you've got this special layer that separates the other parts of the body from the brain as well. Bone cancer, whatever it might be, muscle cancer. There's all kinds of different barriers that the drug has to get through, and then it has to target to those particular areas, which makes it ultimately that much more difficult. Now, the one negative of colorectal cancer is it's actually surrounded by epithelial cells. So if you have a growth of these abnormal cells, that, these cancer cells that are obviously fast dividing, the other cells in that area are also fast dividing. You're constantly recycling through these epithelial cells that make up your intestinal lining. So it does make things pretty tricky, right? Because now you're trying to target this colorectal cancer and you can directly target it. That's great. But what happens to the other cells that also behave a lot like cancer cells? They're not cancer cells, and you don't really want to attack those, right? Because those cells are actually serving a purpose. So there's always trickery. There's always difficulty when it comes to cancer research, and that's what makes it just such a difficult disease to deal with on multiple fronts beyond what I'm discussing here. So Meikson's, the answer is currently only for colorectal cancer as far as I've been able to find. Okay, the next topic is 5 tests for better health. This came about from a centrifuge episode, which I've been having a ton of fun making, these centrifuge episodes, which if you haven't seen any of those episodes, they are, in simple terms, a centrifuge. What it does is that it spins out one thing from another thing. And the idea behind the centrifuge episodes that I release for Physionic is that we're separating out the BS from the truth, the reality, the science-backed information. So what I do is I take health podcasts, health shows, and I used to want to do like the entire podcast. That I can't express to you how much work goes into some of these episodes. Because I'm trying to be as accurate as possible, and I try to give as much leeway as possible, because I also don't want to be seen as unfair. So when a person says, I don't know, it can be some like small comment, I have to spend hours trying to fact check that one small comment, which is like, 30 seconds for them to just say it. And then it's hours for me to have to go back and make sure that comment is correct. And I can know the answer, right? I can know the answer, but the point of the centrifuge is not for me to pit my credentials against somebody else's credentials. That's just relying on authority, as opposed to what the point is for me to show you, okay, here we've got evidence and here we have no evidence, or we have evidence against that claim, right? That's the point. It's not for us to rely on Nick has a PhD, therefore he is correct. That's not the point. So anyway, the centrifuge episodes take a really long time, but that's not what we're here to discuss. The reason why I'm mentioning that is because I did two centrifuge episodes on Dr. Casey Means. Dr. Casey Means she has her doctorate in medicine. I don't think that she's practicing. I'm pretty sure she's not practicing. And I believe she dropped out of her residency near the end of her residency. But anyway, she's put out a lot of different content. She has this book. I don't remember the name of it, but she has at least one book that's out, and she was making this podcast tour, and she was on the Jay Shetty podcast. And in that podcast, she was talking about what 5 tests free or preferably free tests she would suggest that anybody get to make sure that they are above board on their health, like their health is doing well. So her list, I'm going to go through her list, first. Her list was fasting glucose, so fasting blood sugar, triglycerides, blood fats, HDL cholesterol, that's the third one. Fourth is waist circumference, and then finally blood pressure. Okay, so then I went through and I picked out, I went through these 5 and I did a bunch of research, found different studies from different universities and different systems, different governing bodies and whatnot, and try to corroborate, what the correct reference ranges were, if this particular factor, this particular test was the most recommended based on the most current literature. And there were some inconsistencies, I'll just put it this way. So for a lot of it, she was spot on. And keep in mind that this is free or just about free. I mean, really the main focus was it on being free, as in it's covered by your insurance and you don't need to get a special additional test added on. So this is from a basic blood panel that you would get from like your yearly physical. So fasting glucose is a good one. It's not as good, and I know people mention this, well, what about HbA1c or some of these other measures that would be better? What about insulin? And that's all fair. That's all true. But usually, I know some people were saying, well, HbA1c is really cheap where I am. Still, that's an additional cost. That's an additional test on top of your basic blood panel for most people. At least that's been my experience. That's been experience that I've seen across the board on like LabCorp, or if you do Quest Diagnostics or any of those. So I think blood sugar is fine. Fasting glucose. The number for that, so I'm going to give you the numbers, is less than 100 milligrams per deciliter. That would be considered within the healthy range. Anything above that, you're getting into prediabetes and diabetes, obviously, if you go far above that. Okay, the next one was triglycerides. And triglycerides was an interesting one. It's not that I necessarily disagree with that one. It's just that there's much less importance that's placed on triglycerides. And she did make a point in one of the episodes that the reason why we don't focus on something like triglycerides is because we can't, or we don't have a drug to treat it. So that's why it's kind of fallen out of favor. And I have to say, I completely disagree with her on that. I didn't know. So first off, I didn't know the answer. I didn't know, I knew that triglycerides had kind of fallen out of favor. I'm not saying that it has no importance, but it's definitely not one of the main ones that you should definitely be checking. The reason why it's quote unquote fallen out of favor is because there have been drugs that have actually been implemented and tested and whatnot, and they showed no impact. So I don't know about you, but if I'm a pharmaceutical company and I create a drug and I test it in thousands of people and then I see no benefit, how, first of all, the FDA is just going to laugh in your face. They're going to be like, absolutely not. You're not allowed to release this. But secondly, why would I continue to invest money into that, right? What's the point? And beyond that, a lot of the other research that's come out that's not drug related, that's just shown links with triglycerides, when you control for other factors like particle number of LDL particles or VLDL particles or just ApoB in general, suddenly triglycerides play much lower, if any, role whatsoever. And I'll explain that a little bit more in just a little bit. But for now, just know that triglycerides are not very high up on the list. I'm not saying that. So for example, if you have diabetes, there's a pretty good chance that your triglycerides are really high. But does that mean that you should target your triglycerides specifically? The answer is probably not. You should target the diabetes as a whole, and that will probably reduce your triglycerides. But if you were to target your triglycerides but still have diabetes, guess what? You're probably still pretty screwed. Sorry to say. But to put it bluntly, you should focus on the the thing that has the most evidence, which nobody would dispute, that diabetes is going to shorten your lifespan, massively increase your risk of mortality, cardiovascular disease, all kinds of different factors. So that should be the focus. Okay. All right. The next one that she mentions is HDL cholesterol. And I just happened to do a full analysis on HDL cholesterol. And this is a similar story. In fact, it's, I think, even more of a story than it is with triglycerides. Where triglycerides, there could be some arguments made, but HDL cholesterol is, so to describe what HDL cholesterol is, you've probably heard of LDL cholesterol, low density lipoprotein cholesterol. This is high density lipoprotein cholesterol, HDL. And LDL has been linked to cardiovascular disease across many, many different studies to varying levels of strength, and there's multiple reasons for that. But the focus on HDL, she mentions this focus on HDL, and maybe about 20 years ago, researchers and physicians and the governing bodies and whatnot, when I say governing bodies, I'm talking about like the Society of Lipidology or the European Society of Atherosclerosis, and like those kinds of governing bodies. They have, so 20 years ago or so, they did mention, having higher HDL is a good thing to have. And low HDL is linked to all these different disease states. Diabetes, cardiovascular disease, all those different disease states. However, in the last 10 years, 5 to 10 years, pharmaceutical companies, the ones with a ton of money, obviously they're trying to make money, right? So they developed these drugs, and they thought, okay, well, if increasing HDL is what we need to do to improve health outcomes, then that's what we should do. We should focus on HDL. So they developed several drugs, I think at least three different drugs from different pharmaceutical companies that targeted HDL and kind of artificially increased HDL independent of everything else, or at least that was the idea. And they showed repeatedly there was no effect. So if you increase HDL but keep everything else the same, and then you compare to another group of people that do not raise HDL and they also have everything else the same, so talking about LDL, talking about blood sugar, talking about insulin levels, talking about, let's say, triglycerides, talk about your general health, they're not diabetic, all that stuff. Everything else is the same across both groups being compared, but one group has this drug that increases their HDL. There's no difference in mortality, cardiovascular events whatsoever. So that's one huge line of evidence. But of course, there are problems with that, right? There's possibility that the drug has off-target effects. And in fact, there was one drug that did have off-target effects that ultimately led to more deaths, as in its off-target effects, its side effects led to more deaths, which is obviously horrifying. And that they stopped that trial and they said, okay, I think we'll back away from that one. I think we'll pass, which is what they should do. Because again, if you were to try to push that through the FDA, they would laugh in your face. They would say, absolutely not. We won't even entertain the discussion. So then there were some drugs that did not seem to have any side effect, or I shouldn't say didn't have any side effects, but compared to placebo, didn't have any extremely detrimental side effects that would affect the outcome. And ultimately, they still didn't show a benefit. Okay, but that's still one line of evidence. That still doesn't necessarily mean that we should do away with HDL. What about all these correlational studies that showed that higher HDL was linked to better cardiovascular disease mortality and whatnot? Well, again, there were other studies that were done after that, adjusting for some of the new information that we knew, like, for example, ApoB levels, and looking at blood sugar, insulin, et cetera, and suddenly the effect was far more muted. There is still a relationship between extremely high HDL, like over 100 milligrams per deciliter and very low HDL, like, I don't know, like 20 milligrams per deciliter, and how there's kind of this U-shaped curve where people that are very low or very high still have increased risk of mortality. But mortality is kind of a dirty metric, right? It's a good metric in general, like it's informative, but it's not as informative as people like to scream about, which sometimes I get comments, people saying, well, just look at mortality, overall total mortality, all-cause mortality. That's the only thing that matters. Well, okay, let me ask you this. How would you determine the difference between a drug that has an effect, it improves cardiovascular disease, right? So therefore mortality would decrease, total mortality would decrease as a result of improvements in cardiovascular mortality. But what if that drug increased cancer mortality? Now, if those are roughly equal in the number of people that they save lives on the cardiovascular disease mortality, but they increase the risk of cancer mortality, the same number of people, roughly the same number of people die from cancer, the total mortality benefit would be neutral. So now you've lost the nuances of that measure, right? So that's why and this is it's something that's really important for people to understand. Just looking at mortality is not the end all be all. Just because you don't see changes, and there's other reasons why you shouldn't just look at mortality. Now, to be clear, I still love mortality data. That sounds, honestly, that sounds awful. I don't mean it, and I know you understand that. I don't mean it as like, yeah, people died. That's definitely not my point. It's awful that people died, but I'm just talking about the data itself. The actual outcome itself is fantastic, except it has shortcomings, and those can be addressed by being more specific about what you're looking at. If you expect something to improve cardiovascular disease mortality, then that is what you should look at. You can also look at total mortality, but don't be shocked if total mortality does not budge, but cardiovascular disease specific mortality does budge, or cancer mortality, whatever it might be. So I just wanted to quick point that out. So with HDL, there is still this like U-shaped curve where really low or really high, like absurdly high levels is linked, but that doesn't necessarily mean that it's causing. And that's where we're getting into a whole new phase of understanding HDL, because now we're starting to look at the particle quality. And that's something that I discussed a little bit for the insiders in my analysis, but we're still pretty early on in understanding particle quality and its relationship to cardiovascular disease and just health in general. So that's the second line of evidence. We started looking more at the correlational evidence, and we started adjusting for more things that we understood tracked that actually caused cardiovascular mortality, and suddenly the relationship weakened significantly. And then there was a third line of evidence where if you looked at the Mendelian randomization trials, which is essentially people where their genetics indicate that they have elevated HDL that is independent of anything else. So they are automatically randomized. So they're randomly assigned to having high HDL or not having high HDL because of their genetics. And we can look at the relationship that gene has to other molecules, other factors. And if we isolate to just the genes that we are reasonably confident only affect HDL, and we just look at those groups of people versus the people that have normal genes, quote unquote normal genes, and don't have this elevated level of HDL, then we can compare over a lifetime if the people with high HDL have an abnormal protection from cardiovascular disease. And the answer is no. So again, there's no difference between the two groups over a lifetime of having elevated HDL. So we've got three lines of evidence, and we've got more, but those are three massively powerful. I mean, that's like huge amounts of information telling us that HDL is not what you should be targeting. So hopefully I've somewhat explained and convinced you that HDL is not something that you should be super focused on. I'm not saying it has no importance, but it should be pretty low on the list. Okay, the next one was waist circumference. She mentions waist circumference. I think this is a good one, right? Like, so it's a proxy metric for, being overweight, being over fat, having high visceral fat. I think this one's perfectly fine. And then, of course, blood pressure. I think she threw out some numbers that were above what the standard recommendations are currently. The recommendations, I guess, hold on, let me go back to waist circumference. Waist circumference, the numbers were below 40 inches or 102 centimeters for men, and 35 inches or below 88 centimeters for women. Okay. Blood pressure was the current recommendations are below 120 over 80. So 120 systolic, which is the top number, and then 80 as the bottom number. And there are many studies that show that if you reduce your blood pressure, there is a point, where it could be dangerous. But like if you're anywhere like 110 or even 100 or 120, you're not, there's not much risk there. But if you're going like way below that, then there may be a conversation to be had with your physician. But as it stands, having blood pressure in like the 140s and comparing that to people that have their blood pressure in the 120s, no matter how you reduce it, if that's through lifestyle or if that's through drug intervention or whatever it might be, or if the supplements, whatever. Okay, we'll just move on. We'll just say, sure, whatever the reason is, whatever the intervention is, you use it and it drops your blood pressure. You are far better off, and you will have improved or reduced cardiovascular disease risk. Now, let me circle back, using that good old consulting speak. Let me circle back to the HDL. Okay, so my list did change. My list was different. My list, again, with the caveat that these have to be largely free or covered by insurance, basic insurance, or like something you would get at a physical. So fasting glucose is fine. Like, yes, would I love to have, more information like HbA1c or insulin levels, all that stuff? Yes, for sure. But as it stands, fasting glucose. Triglycerides, like I was having a tough time really figuring out one to maybe replace that with. Maybe you could make an argument for like C-reactive protein, CRP, but triglycerides are fine if you know how to think about them in relationship to the next one that I'll mention. So because I said HDL is not that great of a marker, HDL cholesterol, let's remove that one and let's put in, honestly, it's exact opposite, non-HDL cholesterol. Non-HDL cholesterol is a measure of the cholesterol. So remember how I said low density lipoprotein, so LDL, and HDL, so high density lipoprotein? Well, there are others, right? There are intermediate density lipoproteins and there are very low density lipoproteins. And those get all combined into your total cholesterol. So the actual cholesterol that's found inside of these particles. So if you measure the total cholesterol and then you subtract the HDL cholesterol, then you're left with only the LDL, the IDL, and the VLDL. So these kind of major components of cholesterol that are in your bloodstream. Then that gives you an indication of your risk, because those do track and have been shown over and over to cause cardiovascular disease. So it's still not a perfect metric, but it tends to be better than just looking at something like LDL cholesterol, which LDL cholesterol has some association and some relationship and is causative, but because it's not the only factor, it's not as good of a marker as something like non-HDL cholesterol. So that's why I say non-HDL cholesterol, which the metric or the range for that should be less than 130 milligrams per deciliter. Now, another thing that I'll quick point out is that some people pointed out, and I was okay with waist circumference, but some people are saying, well, what about waist to hip ratio, which can give you a more targeted approach, can give you a more exact answer. And I think that's a really good suggestion. Waist to hip ratio. The only problem with it is that it's less common. We have less data on it. And although when compared, from my understanding, which I haven't done a deep dive on this, but from my understanding is when you do compare it against waist circumference alone, there is a better predictive ability of waist to hip ratio. However, that doesn't necessarily mean that you have to do waist to hip ratio. You can still do waist circumference and get a lot of really important information. But considering that it's free and you could do it, I think there's some measurement error that could happen, because when you're measuring the hips compared to the waist, that could introduce some error. But yes, waist to hip ratio is a perfectly reasonable alternative to waist circumference. And of course, blood pressure is fantastic. So my list: fasting glucose, triglycerides, I would put it probably at the very bottom of that list, and I might even switch that out for a C-reactive protein, because it might tell you some more information related to other issues that may be going on that are not necessarily cardiovascular disease. Non-HDL cholesterol for sure. Waist circumference or waist to hip ratio, fine. And blood pressure. Those would be my 5. And of course, there are better tests that are out there as well that you can do for if you want to pay extra or do more with that. Okay, so comments. William Light had this to say. I was chief resident. I taught interns and residents the details of how to interpret laboratory results. This is not taught in medical school, but you learn how to practice and such during internship and residency. Okay, so why is William talking about this? William is talking about this because Dr. Casey Means made a quick comment saying that doctors are not taught how to interpret medical result. I shouldn't say medical results, blood lab results, which I did find incredibly peculiar. But my understanding is that, keep in mind, I'm a PhD, so I went to medical school for my PhD, not for my actual hands-on, blood testing and all that stuff. So like a clinician would, a physician would. So I don't have any firsthand experience to be able to speak to that. I can say from firsthand experience during my master's program, during kinesiology, exercise physiology, we did have to do blood draws, and we had to do analysis of like lab results. We had to do EKGs. We had to do all that stuff. So we were taught. I can say that much, but I just can't speak necessarily for physicians. But I'm hard pressed to say I find it very strange that a physician would not be trained in medical school how to read lab results or what lab results mean. William is saying something kind of in the middle, right? Saying that, okay, it might be true that we were not taught in medical school, but you are taught somewhere along your medical journey. So before you become an attending, you will be educated on these different lab results and whatnot, which is fair enough. I still find it really hard to believe. I mean, look, again, I don't have any first-hand experience, so I can't say. And if you're a doctor and you're listening to this, I'd be curious if you had learned about your just lab results in general, how to read lab results in medical school, or was it later? Was it actually in your residency that you learned that? Regardless, it doesn't really matter, because ultimately you can't, as far as I'm aware, you can't get like an actual job and practice with patients without having gone through some level of additional training after medical school. So I'd just be interested in your take, but thank you for commenting, William. D-Lab R1 had this to say. I want to be proactive in addressing health concerns, and I like a lot of these influencer types because they focus on prevention, nutrition, exercise, sleep, etc. These are big categories that we know are important. However, there are a lot of specifics where I have big questions, e.g. supplements, fasting, very specific timing for eating and exercise, where you could do a lot of good by checking for evidence. Thank you for this series. I appreciate it. And thank you. Yeah, so, yeah, the influencer types. I mean, I could probably talk about this topic for hours. The influencer types, yes, they do put a lot of focus on sleep and exercise generally, and the basics, which I do appreciate. And I think that there are certain areas, especially with the different stories that I've heard, that, some physicians, I certainly don't want to alienate physicians as a whole. Some physicians, don't put enough emphasis on some of these lifestyle factors that you can improve. And there are multiple reasons, myriad reasons for that. So the influencers coming in and saying like, oh, focus on your sleep and make sure, there's research saying that you can improve, like if you do high intensity interval training, that can be extremely beneficial for cardiovascular health or the age of your heart and things of that nature. Then, yeah, I think from that perspective, absolutely. I think that health influencers have been a positive in that regard. I think the tricky part is where we start getting into more speculative categories like supplements, like fasting, let's say, or specific timing of eating, like you mentioned. That's where you're starting to rely on much smaller trials or much smaller studies. So you'll rely on studies of like 12 people in the placebo group and like 14 people in the intervention group. Meanwhile, the pharmaceutical companies can pull together like 3,000 people for their trial. So, so we're, and I do this, right? Like I still cover those studies, but it's always a bit of a cautious story because with small studies, is it really, can you broadly apply it to everyone? Probably not, right? But we just don't have those nuances because there just isn't the money to be able to actually do those trials, on the level of the pharmaceutical industry. And the pharmaceutical industry, they definitely have a lot of really high quality studies that are out there. Let's put aside the fact, the whole like funding and like, the bias and whatnot. I know some people are kind of on a spectrum in relation to their level of trust related to the FDA and pharmaceutical industry and whatnot. And that's fair. But I'm not going to go down that rabbit hole. But if you're looking at small studies, suddenly you're like, okay, so they found an effect. Great. But, is it powered enough to really determine if there are serious side effects? Did it run long enough? All these different things that would be required of the pharmaceutical industry. They are required, if they're going to offer a drug, to do multiple studies on that drug, to have increasingly large sample sizes, to invest millions and millions and millions of dollars into something. And then they have to present that data to the FDA. They have to give over their data. The FDA has a very specific set of criteria that the pharmaceutical industry has to meet. And so with pretty good certainty, because the FDA is pretty strict about a lot of things when it comes to the packages that are delivered, how the pharmaceutical industry packages their information, all that stuff. But with supplements or with fasting studies or any of that stuff, you don't have those restrictions. There's no FDA sitting there saying, oh, well, you didn't do the fasting experiment a certain way, so therefore, you can't do it, or we're not going to approve it, or whatever it might be, because they're just not focused on that kind of stuff. We have, what's it called? I think it's called internal review boards, IRB, where they will, so you have a panel of people that will assess if a study should be allowed to be conducted in the first place for ethical reasons. Are there, potential safety considerations or ethical considerations that restrict a study design or whatever it might be. And that's obviously incredibly valuable to have, and we absolutely have to have that. But, on the back end, are you going to get front end and back end? Are you going to get, billions of dollars to study, like even a super popular supplement like creatine, from different avenues? Like, for example, creatine, like there's tons of research on creatine and muscle and, performance and whatnot. But now we're discovering, okay, maybe there's a potential that it could help our brain as well. But, that started with like pretty small studies. And then we've kind of built onto that literature and just continue to come out with these different trials. But it's not like, because, for example, the pharmaceutical industry, they know that there's no special creatine formula that they can patent and then make a ton of money on. So, of course, that aspect of the pharmaceutical criticism is definitely true, where, of course, they're not going to invest millions of dollars into creatine and creatine research because it's pretty cheap to get, and you just get the cheapest version, right? You just get creatine monohydrate. So are you going to get the funding for like a study with 5,000 people in it where they look at like brain health with creatine supplementation, and they look at, primary outcomes, secondary outcomes, they look at side effects, all that stuff? Like, no, right? You're not going to get that. So that's where I think the reason why I'm mentioning all this is that I think that's where the influencers, they kind of make these false equivalencies of like the drugs that are out there, saying that the supplement has just as much evidence. And sometimes, and I think for nefarious reasons, I think sometimes we demonize drugs and focus so much attention on supplements. And because we're trying to like create this narrative, like the drugs, the pharmaceutical companies, they're only creating damaging things. They're only creating this profiteering kind of mentality, which there's some truth to the whole profit aspect, right? Well, like I mentioned, they're not going to fund studies that they can't make money off this particular molecule. Fair enough. But we also can't be communicating about supplements and whatnot, most supplements, as if they have the same level of evidence that a lot of these drugs have behind them. And that's where health influencers really just make these false equivalencies, or again, they just downgrade the drugs. Oh, don't worry about the drug. Yeah, pharma, that's bad. But this supplement, on the other hand, is top notch. We have 2 studies in 13 people, and it's like, dude, you if you were to stack those 2 together, it is ridiculous how much effort and data is on the drug and how little is on the supplement. And I honestly, I think I probably need to do a better job of that myself. It's not to say that the supplements don't work, but people are so focused on supplements, and so they want to know more about the supplements. They want to know more about the fasting. They want to know more about just basically anything alternative to the things that have been rigorously tested over and over and over again, which, again, is fair. And there's a lot of excitement there. And I get excited about certain molecules, like the Berberine thing, for example. That's why I try to point out, like, hey, we have one study, or Glycine. We've got multiple studies, but they all come out of one lab. And the effect size is huge for like Glycine. Like, it's pretty remarkable. I'm still a pretty big fan. I'm just kind of cautious about the fact that it's all out of one lab. And it doesn't go through this like special testing and all that stuff. So yeah, I'll close it with this. Just health influencers, yes, they've had some positive impact. I just think that sometimes it gets pushed beyond the positive, and it definitely turns into a negative, and it can create a lot of uncertainty, and it creates a lot of false equivalency between like, different supplements saying, oh, well, this works for this and this works for this and this works for that. And now we can stack all these supplements. And it's like, we don't have any evidence that you can stack these 4 things together and suddenly you'll just be better off than if you had done this other thing that's got tons of research behind it, but it's just not as sexy. But, we as humans just like to be, for some people, they just want to be cutting edge. They want to be the person telling everybody, yeah, I'm taking green leaf extract out of a monkey's butthole, and it's just like the best thing in the world. You got to stop the Ozempic. You got to stop the statins. You got to, that's old news, man. It's all pharma stuff. Monkey butthole, green leaf extract. That's going to be the new frontier. Meanwhile, if the pharmaceutical companies sniffed even for a moment that worked, they'd be on it. They would be on it. And there's certainly discoveries like the new, I'm going to pronounce it correctly this time, retatrutide peptide, which I have more content coming out soon on. I'm pretty sure that was at least partly funded by public funding, so NIH funding, and that is an incredible peptide. I'm sure there's going to be side effects with it because it's so potent. But in terms of the effect related to side effects, like aside from the normal side effects that you experience with a lot of these like different GLP-1 receptor agonist peptides, which are gastrointestinal discomfort, nausea, maybe vomiting and whatnot, which isn't fun. We need to acknowledge that. That's not fun. But if you dose it correctly, like retatrutide has some incredible, like some effects that are beyond what we've ever seen before. And I'm very excited to cover that. So definitely look for that. I've already finished my research into that. I've already done all the notes for my video and all that. So I'll in the article, and I'll put all that out in several weeks. So yeah, there's definitely discoveries that we're making that are kind of unexpected. And then, pharmaceutical industry jumps on it and tries to figure out a way to patent it, right, to make money. But ultimately, it still leads to significant benefit. So, it's just, I'll get off this. Like I said, I could talk about this for hours. I've got many opinions on the topic, but I'll leave it there. In short, health influencers have done some good. They've also done some negative. And in terms of supplements, fasting, very specific timing and all that, I'm going to continue to cover that stuff because that's what people want. I have to follow what people want to a degree. But I also, I have to always check myself and make sure that I'm doing it responsibly because telling that information, like you want to weave a story, you want to get people excited, but you also want to hit them with like honest truth, like, hey, look, this is a study in 12 people, or there's no placebo group here, or I don't know, any number of different things. Like, we don't have safety data on this. Like, this was in a mouse, like whatever it might be. So you have to be honest with that kind of stuff too. Okay. The next topic, ladies and gentlemen, is glycine. Restricting glycine led to a reversal of cancer. Okay, this was a hot topic. So there was this phase 1 clinical trial that released, I believe in December, maybe November, and I covered it in December. And in this study, they showed, this was a cell metabolism study, they showed that people that were put on a specialized diet where they ate basically no glycine and basically no serine, so those are 2 amino acids, that they experienced significant reversal of cancer. And there was this really punchy image of this person with colorectal cancer had this massive tumor. And after being placed on this diet, and it was actually, I think, only like 9 weeks. So after 9 weeks, they showed the image of that same tumor, that same site, and it was just gone, which is just like, what? Just by restricting 2 amino acids. Of course, this is with immunotherapy. So basically all cancer research, you're almost never going to get research that's just like, hey, what happens if we just restrict this one amino acid? Good luck. Hope you don't die. It's definitely going to be, here's our standard protocol. And then on top of that, would you be interested in trying something novel, something new to see? Novel, new, I just said the same thing, to see if that could have additional benefit. And of course, it would help scientists. And if there's any sort of harm that we, detect that there's some sort of harm, we'll stop, of course, because again, ethics, incredibly important. So they showed that when these people, it wasn't a big trial, right? It's phase 1. So these people were on this restrictive diet. Some of them were on for only 3 weeks. Some of them were on for 6 weeks. Some of them were on for the full 9 weeks. And they showed that there was, for most people, at least some regression in cancer. And some people were able to see huge decreases in tumors, like tumor size, to essentially it being undetectable by by visual, by the eye. Okay, so cool. That's pretty impressive. I mean, that's actually, I would say, incredibly impressive. But then, of course, because glycine is such a popular supplement, people were, and I knew this was going to happen. So I added in my initial analysis, I said, does this mean that you should stop supplementing glycine? The answer is no. So that seems weird, right? To say, well, hold on. If I restrict glycine, I get rid of cancer, but I shouldn't restrict glycine. I should keep supplementing with glycine. Okay, so the reason why I mentioned that was multiple reasons. Initially, it was for one main reason, then that reason grew into multiple other reasons as I went over some more literature. So the answer was that, one, if you don't have cancer, then this doesn't apply to you, right? Like we're talking about a pathology. So in that situation, if you don't have cancer, then continue supplementing with glycine. There are multiple studies indicating benefits. I went over Glynac a little bit, and there are others as well. So no reason to stop for that. It's not, at no point was there a claim by the researchers or by me that glycine causes cancer. Like if you increase your glycine intake, that now you are more likely to develop cancer. So no one was saying that. So for the vast majority of people, cool. Then even if you have cancer, now we've got 2 amino acids that we're restricting at the same time. And people could argue, well, they should have only restricted 1. Well, you have limited resources and you have to make a choice. And based off of the preclinical data that had been done before that, they had restricted both amino acids. So they can't get to the clinical data and be like 50-50 guys, maybe it's both have to be restricted. Maybe it's just one that has to be restricted. Like, are we going to take a gamble and guess like which one we're going to restrict and just kind of hope that it does something? No, they just followed what the preclinical data did and they translated it to humans. So they restricted serine and they restricted glycine at the same time. So even if a person has cancer, like we can't jump to any conclusion. We can't say, oh, well, you should stop glycine. This is a phase 1 trial. There's no control group. So we don't know what would happen if we controlled for people that were just on the immunotherapy. This included multiple types of cancer, colorectal, breast, like a bunch of different types of cancer. And it was very heterogeneous. So as in like some people experienced significant improvements and other people did not experience improvements, as in some people still progressed in their cancer. The problem is we don't have a control group. So we don't know if they progress slower in their cancer than people that were in the control group because there was no control group. So many different questions. So we don't change behavior based off of early data. I mean, that is a risk that you as an individual can take, but no physician, and I'm not a physician, but I wouldn't say, oh, now just start cutting all your glycine because this one study that cut 2 different amino acids said, there might be a benefit. That's just not responsible communication. So yeah, for cancer, there's a lot more uncertainty. But at least what we can also say is that there's research that's getting further along that's looking at this and seeing if there may be certain cancers that may be susceptible to glycine restriction and serine restriction, so the combination. Okay, now then I revisited the topic because then I was curious and I asked myself, well, is it the glycine restriction or is it the serine restriction that's causing, or is it both? And I found some other studies that were preclinical, so we're not talking about clinical research anymore, where they applied a dual restriction to animals as well as to cells. And what they found is that when they fed the cancer cells, or when they restricted both serine and glycine, they were able to repeat the experiment, what we saw with the clinical data, that cancer had more difficulty growing, significantly greater difficulty growing, and would die more and was just generally more stressed. Then they did additional experiments where they separated the two, right? Where they only restricted serine or they only restricted glycine. And when they restricted glycine, there was no reduction in cancer. But when they restricted serine, there was a reduction in cancer. So now this tells us, or at least it gives us some clues, that the effect is not driven through glycine, it's driven through serine. It's the serine restriction that's most likely causing all these effects. That I just want to pause here. It still doesn't mean that we should now restrict serine. We're talking about preclinical, we're talking about less than preclinical, we're talking about cell studies, but it's teasing out the mechanisms of how this works. Then there was a specific study that did all these tracing experiments where they literally tag molecules of glycine and tag molecules of serine, and they watch, not like by eye, but they measure through many different experiments what happens, where these tagged serine molecules and glycine molecules end up in cancer cells, in a variety of different cancer cells. And they showed that if you restricted serine, or if you increased glycine, so you increase glycine, not restrict, but increase glycine, is that there's a pool of glycine that builds up within the cells that reverses a particular biochemical process. So I'm going to break that down. Typically what would happen is serine inside your cancer cell, but also inside your regular cells, would convert serine to glycine. Okay, so that's all you need to know. Serine gets converted to glycine. In that conversion process, there is a loss or a production, we'll call it a loss, of a carbon atom. So that carbon atom will then go down a different pathway. So we've got serine to glycine, and the conversion from serine to glycine means that a carbon is removed off of the serine molecule. And as a result, that carbon molecule goes down a different pathway, which ultimately results in greater production of nucleic acids. What are nucleic acids? Nucleic acids are involved in the production of DNA. So in the building blocks for DNA. So obviously, if you have a dividing cell that needs to replicate all of its DNA, then those carbons are incredibly important, right? You're getting more of these carbons shuttling off into this system that then, gets used for DNA synthesis. And then therefore you get more cancer cells. So the cancer cells get to grow. So if you restrict serine, well, obviously then you don't have any conversion to glycine because, well, there's no serine. Okay, so none of those carbons are going across because they just don't exist. But on the other hand, if you up glycine, then the pool of serine is smaller than the pool of glycine in that scenario. So now the reaction goes in the reverse. So now instead of losing a carbon down this pathway, you are taking carbons from that pathway and putting it onto glycine to create serine. So what does that do? Well, now you're, instead of adding things to, it's like instead of adding things to a house that you're building, you're now taking different elements from that house every time that you need something and putting it somewhere else. So is the house being built, or is it being destroyed, or is it being broken down? Obviously it's being broken down. And that's the same with the cancer cell. So now the cancer cell no longer has this reservoir, or this pipeline, I should say, of carbon. Okay, I had to pause there for a second because a trash truck just went by and made a whole ruckus. So hopefully I didn't lose my train of thought too much. But essentially, as I was saying, hopefully I was saying that you have this carbon that no longer then gets sent down this pipeline, and ultimately you get this stopping or slowing of the cancer growth, because the cancer cell no longer can rely on those carbons to go down and produce these nucleic acids, to produce these DNA pieces that are put together. So that's the idea of the serine restriction, or the potentially the increase in glycine, which is definitely in preclinical models as well. So we don't have clinical data on that aspect. So based on early data, cell work, some in vivo work, so in animals, we have evidence that the real culprit is serine restriction. That is the one that's going to be beneficial, and not the glycine restriction. And maybe we'll get that in clinical trials in the future. But as it stands, that's where we are. Is this actionable? Like, I know this is always really tricky, because people are often in stressful situations where they have to deal with cancer and whatnot. And I can't give you advice. Like, it's one, I'm not your physician. Like, I simply cannot. And I refuse to tell people, oh yes, definitely do this and definitely do that, and then do this, based on exactly what I was just railing against before about, these like early signs of data. And then I'm not distinguishing what is rock solid evidence we have and what is kind of like, we're not sure, or we're early, or we don't have any real clue what we're talking about in this category. Like, so sometimes people will reach out and be like, hey, I have leukemia, or I have skin cancer, I have melanoma, or I have like whatever type of cancer. And I just can't, like, I always respond the same way. I can't tell you what exactly you should do. It's not ethical for me. And it's, again, I'm not your physician. So I don't know all the details of your special circumstance and whatnot. And all I'm going to ethically tell you is that we're very early in the research. We at least have like a little bit of clinical evidence, which is great. And if you wanted to do it, I mean, that's on you. That's, your choice that you need to discuss with your physician. I know everybody, there's a lot of people that scoff, my physician, they don't know, what they're talking about, and like, it sucks. Like, if you have a bad relationship with your physician, I can't, again, it's out of my wheelhouse. But if anybody ever wants to get more experimental, it's your body. But my only advice ever is to at least consult with a physician that actually knows your circumstance. So is any of this stuff that I just went over actionable? No, because at the very top, we have a phase 1 clinical trial. No one would base huge, like, yes, we have definitive evidence based on a single phase 1 clinical trial, which, by the way, also still had some people progress in their cancer. The majority didn't. And a lot of people had regression, but some people still had progression. So there's a lot of uncertainty still. So anyway, I'll get off my soapbox, but let's go over some comments here related to the topic. And the takeaway here is that glycine is probably not the issue. Okay. So if you're supplementing with glycine, my estimation based on early data and with no data on specific cancers, that's a big caveat there, that glycine supplementation is unlikely to be the issue. Okay, so Hawk Driver said, I'm down to celery and lemons. Everything else seems destined to kill us. And it does feel that way, right? Yeah, it does feel that way. You get told on social media by health influencers, myself included, that you should consume more glycine because it'll turn your gray hair back to their normal color. You take glycine and your immune system will be supercharged and like all this stuff, right? You just get told all kinds of different things. And I'm not even necessarily saying that some of those videos aren't correct. Like some of them can be right. They can be focused on evidence. They present that evidence and it's all above board. I think it's the fault of both sides, honestly. And I've been saying this for a long time now, and I'll probably continue to say it for the rest of my life, that on one side, the health influencers, myself included, have to constantly be working on how we communicate and how do we communicate ethically, how do we communicate correctly, while still, and I will, like in defense, I will say, like if your livelihood is on social media and science or just communication, health communication, doesn't even necessarily have to be science communication. Just giving information, just like all the information right at the get-go, like right at the beginning, people really complain about that. Like, oh, well, why did I have to watch an 8-minute video to understand this? And it's like, well, for me, there's two reasons. One is what I'm talking about. We make no money, so we just go extinct. So all the benefits from like having health influencers and stuff just goes extinct if we don't have a story that we can tell. And the other aspect is like, honestly, I don't like people that aren't curious, that don't want to understand how these things work, aren't asking questions. And if you're the type of person that just wants the answer and then like, I'm just, thanks, see ya. You and I are not this same type of person. I just don't like that. I don't want to foster content that's just, here's the answer. Just believe me because I have a PhD. Just believe me because I flashed a study. Look at this study. And meanwhile, I'm not demonstrating to you, hey, look, I read this. I analyzed it. I know what I'm doing. Here are the statistics, understand some. I'm not saying like the whole thing because I realize that can be a bridge too far. That can be a little too far where it gets too into the weeds. But, still, it should be on me to present to you and to say, look, this is what the evidence shows. This is what the evidence doesn't show. Because if I give you a quick answer and you run with it, that's the problem. That's where we end up with, I'm down to celery and lemons. Everything else seems destined to kill us because now I'm not doing, like you're not doing your due diligence of like having a bit of patience and understanding the context around what we're talking about. So let's return to this glycine scenario, right? The glycine scenario is like, okay, it can be beneficial, let's say, against insulin resistance, like mild insulin resistance, or it can be beneficial in GlyNAC, right, for the combination of glycine plus N-acetylcysteine, and it can improve muscle function or mitochondrial dysfunction or whatever, just it can be a number of different things. But let's say there was this study that also showed that glycine is a negative if you have melanoma. Very specifically, let's just say, and I'm not stating this as if there is a study, to be clear, but let's say there is a study that says glycine fed to people that with melanoma made melanoma grow more quickly. Okay, so does that translate that glycine is now something to be avoided by everyone? No, right? No one in their right mind would actually say, oh, well, now I can't take glycine. It's like, that's not how this works. That's not how nuance works. That's not how an educated person thinks. Like an educated person thinks, okay, check one, do I have melanoma? Answer no, therefore does not apply to me. That's how you typically think about things. So like, and I see this so often, people just cross off an entire nutrient or an entire food group or an entire exercise or whatever because a single study showed that there is a negative for a very specific group of people, and they don't fit any of those criteria, but they just cross it off. And then we get these complaints of like, well, one day they say this, and then the next day they say that, and then the other day, and it's like, I don't know how many times in my videos that I've pulled together like 10 different studies, and 8 of them say kind of something in the same realm, and then 2 of the studies disagree. And it's like, if you were to actually read all those studies, you would understand, oh, maybe those 2 studies were in particular, like they were in, let's say, women, and the 8 other studies were in men. Okay, so maybe that's the defining feature of maybe this is a negative for women and it may be a benefit for men. Wow, look at that. We have nuance. Now we have some understanding of it affects people differently. And you have to understand your circumstance. Does that actually apply to you? Do you fit the bill here? And if you don't, then don't worry about it. This doesn't apply to you. Don't cross it off just because there's a study or a few studies or whatever it might be. Now, on the other side, the health influencer has to do a good job of explaining that, hey, this was in overweight people. This was in people that were in their 60s. There was other studies in people that were in their 30s and it had no effect or whatever it might be. Like, that's where the health influencer, the communicator, has to be better. And this is something I'm constantly working on, to give all the information that's pertinent, that needs to be said, so that a person can make that categorization, that like, oh, do I fit in this bucket or not? As opposed to just saying moringa powder is the best thing in the world. You put it in a coffee and your visceral fat gets cut by 1,000%, not possible, but by 1,000%. You turn into Brad Pitt, and like all these different things. It's just like the best thing ever. And then the next video, glycine supplementation, that's the thing that's going to cure your insomnia, and like all these different things. And then people try it, and then it's like, okay, maybe it worked, maybe it did. There's just so much to be said. So that's where you, like, picking the people that are going to be more nuanced and actually have those discussions is critically important. And for the viewer, for that person to really sit and think and like, okay, does this apply to me in this situation? And generally the answer is no, right? Okay, anyway. Party DME. I'm pretty sure it's Party DM. I swear every time I start something for supposed health benefits, YouTube pops up a video showing how detrimental it is. What the hell? Okay, so I'm not going to repeat it, but same story. Again, just context. Following people that will actually sit down and explain, okay, maybe it might affect these people. It's probably not going to affect these people, so you're probably okay. And at the same time, the viewer having the patience to sit there and be like, okay, I'm going to sit down for this 10-minute video and watch it, and help this content creator continue to be ethical and all that, do the right thing, which they should be doing regardless. And at the same time, also, I'm going to put it upon myself to learn this context and understand everything that needs to be said, so that I can make those distinctions. So I'm not in this like, what the hell kind of scenario. Sabrina said, I'm truly confused. I thought glycine was an anti-cancer, an anti-aging, an antioxidant. It seems that every other week that we get conflicting information. I feel that anything is cancer-inducing at this point. I think the best way to live is just to enjoy life and to avoid any obvious toxins such as tobacco, alcohol, and drugs, including sugar, and leave it to the man upstairs. The more I educate, quote unquote, myself, the more I feel that I have no idea what's going on. Okay, this is kind of in the same vein, right? But in addition to that, I agree with Sabrina that, just focusing the big levers, the huge levers to pull on are definitely, just enjoy life. Avoid obvious things like tobacco, alcohol. It's not like there's going to be a study that's going to come out and say like, hey, tobacco, we were wrong about tobacco. Tobacco is actually really good for you. It's absolutely fantastic for you. Nobody's going to say that. Like, there's certain things that are really, it wouldn't shock me if we had a study that showed that a particular group of people that have this particular gene expressed may not experience the negative effects of tobacco. Could that happen? Yes. But does that then translate to everybody? Hey, tobacco is no longer an issue? No, you're not going to see that. So yes, to Sabrina's point, like the big levers, exercise, nutrition, making sure you avoid tobacco, smoking, vaping, alcohol, drugs, of course. I don't know if I'd necessarily include sugar. Like, people kind of talk about sugar like it's like some specific thing that's not really a nutrient, when in reality it gets broken down inside your body the exact same. If it comes from white bread, if it comes from wheat, if it comes from Fruity Loops, whatever, like cereal, whatever it is, ultimately it gets broken down into glucose, and that's what gets absorbed into your bloodstream. So it's a whole nother conversation, and there's certainly some nuances there to also be had. But would I put that on the same category as like actual drugs, like, I don't know, heroin or something? No, not even close. And in fact, you can check out, I did one on fructose, centrifuge episode on fructose, and Dr. Lustig, who's huge against fructose. And, there's some reasoning for that. But so I'd encourage that you check that out. But yeah, I mean, these comments, again, like they're among my top comments, and so this sentiment is continuous. People really feel strongly that, health influencers are saying one thing and then they're saying something completely different the next day, the next week, whatever. I totally get that. I'm not immune. I definitely understand that. And I get frustrated. Why do you think I started the centrifuge? Like, it's so much work, but I feel so passionately that people are just miscommunicating. And I'll even say it as far as malcommunicating. The distinction in my head is miscommunication could be like, they don't know any better. I'll be honest, I really think, I'm not going to name any names, but I get the impression that some health influencers are actually like, they don't care if they hurt people, because it's not direct. It's just, I'm just providing information. But like the gross negligence in certain scenarios, and especially when people get called out and said, hey, you missed this thing, and it's like a huge thing, or you missed like all these different factors, or the study that you were talking about didn't conclude any of what you just said. I mean, that kind of stuff. Like, I understand people have, like, sometimes they have such big platforms. Like, I miss a lot, and that's why I've got like a critique page, so people can click on the link and send me a direct critique. People abuse that all the time. But aside from that, I have received critiques, and I take great pride in the fact that I will read that comment, especially if it comes from a researcher or a physician but it can be anyone, right? As long as they provide proof, like evidence that I got something wrong or whatever. I remember once I royally messed up on a meta-analysis, and I've learned a lot since then. But there was this meta-analysis researcher that actually conducted meta-analysis, and she really laid into me. I could tell she was just really frustrated with just like bad information being put out there. It wasn't like, I was misleading the public or anything like that, but just like there was a few statistical things that I was explaining in certain ways that she didn't agree with. And she was more of an expert on the topic than I was. So she sent me this long thing. And at the end, like, she was like, I don't even know if you're going to read this. Which, like, I understood, like, it was her field, the thing that she was really passionate about, and she was just like letting me know. And I'm glad that she did. I'm really glad that she did, because I reached out to her the next day. I was like, hey, do you mind if we hop on a video call? And she ended up like apologizing for like being so aggressive towards me and everything. And we had a lovely conversation, and she taught me, and I said, like, hey, in the future, maybe we can have more of these conversations. I'd be happy to pay for your time. And we've had other conversations, just like spoken in general, just on video chat and email and whatnot. And it's, yeah, I mean, and I took the video down. I posted a notice, like an amendment for whatever needed to be fixed. And then I contacted her about like a few different resources that I could read to learn more about the topic. So this was like on a very particular like statistical modeling in meta-analyses. And she was really kind. She sent me a few resources, and I ended up buying a book. And honestly, it's dense. I've gotten about like 3/4 of the way through it, and I'm probably going to have to go through it again, but it's a wonderful resource. Anyway, the short story of this is that it's incredibly important for me to get things right. And if I get things wrong so that I can get things right, then I'm willing to do that. That is perfectly fine. I'm not above, like, my pride isn't going to jump over the potential that I could be harming other people. That will never happen. And, since then, because again, I'm growing and I'm trying to improve, I've hired statisticians before to check over some of my work. Not every video, but like for some of the things that I'm not quite sure on. And now we've got AI. I know that AI can have its issues, and of course I fact check that information too. But it's just important. So when I see some health influencers just post information, and again, just to repeat, I understand some people have millions of subscribers, so they're not going to get every email. But when you have a groundswell of people that are like, hey, this person screwed up, and here's the evidence, and like they clearly didn't read the study or whatever it might be. It could be anything. And that person doesn't, address the issue. I'm not talking about like, hey, I don't like the way this person talks or whatever. I'm talking about scientific evidence. Like they're just not addressing data. They got a lot of things wrong, all that stuff. That is stuff that you should address. If you're a science communicator, that is something that you need to take down videos. You need to send, post amendments. And that's why under my videos, sometimes I'll post minor amendments if I get something wrong. I think recently I did one on polyunsaturated fats being converted. So I accidentally had an image of a saturated fat being converted to an omega-3. And I do check my comments in the first like hour or so of posting. I try to engage as much as I can. And somebody pointed that out and said, hey, you messed this up, which I'm glad. So I checked, and sure enough, I had a saturated fat being converted to, I think, an omega-3. And that can't happen. That doesn't happen in the human body. What happens is you have unsaturated fats that are elongated into omega-3s. So I posted an amendment, and I added it to my articles and all that stuff. So again, the point here is that there's a lot of health influencers that are putting out just trash information. And honestly, I think some of them know that it's trash information and they just don't care. So when I get comments like the ones that I just did, that I just pointed out, it's not people saying like, hey, I heard glycine is good for this. Like they're just expressing their frustration that there's so much information out there that one day they say this, one day they say that. I'm with you. Like I'm on the same page. And I think that the issue is two-sided. The health influencers and some viewers. So some health influencers and some viewers, not everyone, obviously. Yeah, anyway, I'll move on. All right. The next topic that I wanted to get into is to get into my favorite anti-aging hack. And this anti-aging hack is an incredibly simple one. It is sunscreen, which I know isn't all that exciting, but it is important, at least from an aging perspective, and certainly you could argue from a cancer perspective, or at least skin cancer perspective. So I released this analysis where I just did this not because this is some miraculous discovery or anything like that, certainly not. But I did want to cover this simply because I am a pretty big sunscreen fanatic. And I was just curious as to what kind of impact wearing sunscreen on a daily basis, like right now I'm wearing sunscreen, of course, certainly when I'm outdoors, but I even wear it indoors, what kind of impact that sunscreen would have on aging metrics. So I found a number of different studies on the topic, and admittedly, those studies are not very high quality, at least some of them, but all of them point the same direction, and probably isn't too much of a shock to know that sunscreen can significantly slow, and in one study actually completely stop visible signs of aging. And I've been a pretty big fan of sunscreen since I was about 28, and I am now closer to 40 than I am to 30. And I think, at least from my estimation, I think that it's helped. I'm not saying that it stops skin aging or anything of that nature, but I think that it definitely has a significant impact. And I don't think that it's something that we should overlook, even though it may not be very sexy, right? It's not like taking some super supplement or something like that, like NAD boosters or anything like that, that's suddenly going to rejuvenate your cells back to their 18-year-old versions. But especially if you jump on it early in life, I think you can have a really substantial impact on the way you look, at least. Certainly that doesn't necessarily speak to your liver health and your heart health and all these different other aspects. And in that regard, you probably have to do other things, obviously exercise being one of them. And there's even evidence, and I've covered this before, that exercise can be helped, that skin can be helped through exercise as well, as in if you exercise, your skin tends to be better for it as well. So do I think that sunscreen will stop aging like that one study showed? There's this one study that compared, I think, like infrequent to no sunscreen use versus a group that was told to use sunscreen, I think, every single day. And they showed that the group that used sunscreen every day for 4.5 years, something like that, 5 years, was able to completely stop their aging, skin aging. And that was determined by, I believe, blinded dermatologists. Now, does that actually mean that these people were completely not aging whatsoever? I don't think so. I think what's probably happening is that it slows it to such a degree that it seems like these people haven't aged over the last 5 years. But I think if they'd use some more objective metrics like actual collagen levels, or if they'd done some sort of ultrasound or different echo technologies to really figure out the density of the collagen or the different fibers that are within the skin or the skin cells themselves, I'm pretty sure that they would have discovered some sort of an effect, as in these people were still aging over time. Still, not bad. I mean, if you're, 5 years isn't like a monumental amount of time, but it's certainly something. And I think it's pretty impressive that you can just put something on your skin and it can protect you from UV radiation, which is the primary method by which sunscreen helps against skin aging. And of course, in my latter part of my analysis, I went over a few intervention trials looking at skin cancer and showed that the sunscreen can also reduce our risk of skin cancer by a pretty substantial amount. So, all in all, definitely something that I encourage people that want to retain as much of their skin youth as possible. Okay, so that brings me to kind of to another part of that analysis, which I know that a lot of people are skeptical of sunscreens because they are endocrine disruptors and a bunch of other, things that have been said in the past. And I'll admit that I did look at the studies on that, and I'll admit that there are not very many studies that have actually specifically looked to check if sunscreens are safe in the doses that are applied. There's one study that looked at the hormonal changes over some number of months, and they did show that there was a slight change in hormonal profile from sunscreen use, I think in the first month, and then after follow-up, so continuing to use sunscreen, but in follow-up, 2-3 months later, their hormones returned back to before they were using sunscreen. So how applicable any of that is, like what difference is that going to make? I don't know. And I don't think it's probably something that you need to really worry about a whole lot. The other aspect is, I looked at like sunscreen and mortality there, and other some like kind of major metrics like what we discussed earlier, and there doesn't seem to be much of a link. I will say that again, there isn't like a whole lot of literature. If people are under the impression that there's a ton of literature that shows that where we've applied sunscreen and then we've measured cardiovascular health, then we've measured cancer, then we've measured all these different things. We've measured, I don't know, like all kinds of different niche conditions and then determined, it's all good to go. That's not how the literature actually looks. The literature, there's quite a few studies on sunscreen, but there just aren't enough to cover all of our bases. Really, it's deemed safe because of the ingredients are in such small quantities that the governing bodies just deem them as highly unlikely to have any sort of impact. And that's because in terms of like blood impact and organ impact and whatnot. And the reason for that is just because there has to be a certain threshold at which you are getting exposed to a particular molecule. And when it comes to sunscreen ingredients, the threshold, just like with many other things, like aspartame and sucralose and all these other things, I'm just coming up with different molecules that are deemed as like such small amounts of it that it's assumed that there isn't that much of an impact or any impact on your organs in any sort of negative way, simply because you are consuming such a small amount by comparison to what's deemed actually dangerous based off of like animal studies and sort of some of the biochemical studies. So and also, even if you were to have some small impact, how much would that translate over time? That's another aspect. If you have a minuscule effect, is that going to outweigh the huge benefit that you get to your skin aging, but even more importantly, probably skin cancer? So, and there's certainly other ways of going about it. Like there's also physical types of sunscreen, there's physical blocks, and then there's chemical blocks. I don't really care that much about the distinction, but some people really do care, and that's perfectly fair. There are advantages and disadvantages to both. Some of them are just more cosmetic. And I don't use really high SPF. I use SPF 15 and SPF 30. SPF 15 when it's not very sunny out, when it's not like middle of summer. Middle of summer, I usually use SPF 30. I use it on my skin, my neck, and I will put it on my arms. I actually forgot to do that right now, and you can see I'm getting a lot of sun exposure at the moment. I'm not going to fret about it, but I probably will get sunburnt unless I move out of the way. So you know what? I'm going to move a little bit back Ha! I've outsmarted the sun. Okay, so yeah, so that's where I kind of land on this favorite anti-aging hack. Again, we get so focused on the different consumables, and I'm not saying that they don't have an impact, but some of the stuff is so obvious, right? Like just exercise, or just dial in your nutrition, or even just broad strokes. You know, if you're overweight and you're worried about like NMN supplementation, what are you doing? You should be focused on getting weight under control, because that is going to have mass more impact than like NMN supplementation, for example, or whatever it might be. So, and I think sunscreen is just one of those, especially in summer, that is just such a no-brainer. And if you want to go other routes, like if you want to protect your skin through other routes, like wearing more clothing, like sun protective clothing or whatever it might be, then that's a way to go. Now, one of the critiques, I don't know if I've got some comments here. Oh yeah. Okay, so I'm gonna cover one of the major critiques that was presented to me based on what I was talking about in terms of sunscreen. So just as a final word, the way the sunscreen protects us is from extrinsic versions of, or extrinsic factors of aging, meaning that you have something from outside of the body that's affecting the body and then causing aging. And same thing, same exact route for cancer in this situation, because we're talking about UV radiation, and that's going to be important in just a minute. So UV radiation has an impact on our skin, which ultimately breaks down our skin, and or I shouldn't say the skin itself. It has an impact on the DNA that's within our keratinocytes, which are the skin cells, and then they don't function as well because they're constantly repairing this DNA damage, which ultimately can lead to, of course, cancer, but can also lead to dysregulation of the cells. Essentially, the cells just don't connect with one another because there's these different kind of think of them like anchoring proteins, where they anchor onto one another like they're holding hands almost, and that can get dysregulated so that the cells are not as bound to one another, so you've got less of a skin barrier integrity. Obviously, it can affect the collagen fibers that go through the epidermis, which is a section of your skin, which creates the actual like lattice structure that holds the skin up. So there's a number of different things, and the sunblock, sunscreen, can, depending on which one you're using, essentially just has the UV interact with it instead of interacting with all those different components that I just talked about. And there's many other factors. And then there's intrinsic aging, which is something that we can't really avoid. It's just chronological age. You know, as time passes, our cells are imperfect, so they're going to make replication errors and all kinds of other things, which ultimately leads us to have problems that we try to avoid, right, through supplementation, exercise, nutrition, all that good stuff, and potentially gene editing or gene therapies in the future, or gene whatever, or stem cells, or all kinds of different medical technologies for the future. But those are things that are, you know, they're not necessarily, I guess they can be preventative, but generally it's going to be extremely difficult to get people to reverse their aging to that degree, because there's so many intrinsic factors that happen in all kinds of different organ systems that we have to account for, and it's just not always possible. So, okay, so now let me... So that's all to say, sunscreen specifically affects extrinsic aging. It has no real impact on intrinsic aging. Okay, so let's go into some comments. So Patrick said, again, these are the top comments, or among the top comments. Patrick was surprised that I had said in my analysis that I was closer to 40 than I am to 30, and mentioned that sunscreen was working for me, which I appreciate. Thank you, Patrick. The Final Roman said, which sunscreen do you use? So like I said, I don't use very strong sunscreen, SPF 15, SPF 30. I reapply often, 2-3 times a day, especially when I'm outdoors. I apply pretty regularly. I always wear sunscreen. I know people will think that's kind of crazy to be wearing sunscreen every single day. I use it every single day. It doesn't matter if I'm going outside or staying indoors. I wear it all the time. That's definitely why I'm as pale as I am. And the type of sunscreen that I use is Cetaphil. But I'm not like, it's not because Cetaphil is some sort of specialty brand or anything like that. It's legitimately just because it's cheap. I don't get it in my eyes. It just goes across my skin really well. And the other, there is a particular type of sunscreen ingredient that I truly wish would get approved in the United States. I think it's called bimotrizinol, and that is probably going to be like a golden child of sunscreen ingredients. And for some reason, I shouldn't say some reason, the FDA has not approved any new sunscreen ingredients in like 20 years, if not more. And bimotrizinol is one of those that's approved in like the EU, Australia, and all these other places. That's just not approved in the US, which is unfortunate because apparently it's better at blocking UVA and UVB radiation. But on top of that, it also doesn't leach into the blood, which certain chemical sunscreens do leach into the blood. And then you can, be pretty safe in assuming that you're not going to have any sort of consequences. I still don't think that there are going to be any consequences of those trace amounts of sunscreen ingredient leaching in. But I know a lot of people are like, well, look, I mean, it leaching into my blood is already scary enough, which is totally fair. Like, I respect that. Bimotrizinol, I hope I'm getting the ingredient correct, is something that I would just love to see actually get approved, and hopefully in the future we will. And the moment that does, whatever company uses that, I'm going to switch over to that. But yeah, SPF 15, I use Cetaphil, but I'm pretty ambivalent. I could go either way to any one of the other ingredients. I've tried a few others. I just don't like the feel of them on my skin. Okay, then the critique. Now this comes from Lenny. So Lenny, you should take a look at the UK Biobank study. This is an AI overview when asked about it and sun exposure. Okay. So UK Biobank studies study particularly analyses of over 370,000 to 400,000 participants by the University of Edinburgh suggest that higher ultraviolet exposure from sun or sunbeds is associated with lower all-cause cardiovascular and cancer mortality. These findings indicate that in low sunlight, high altitude regions, the cardiovascular benefits of sun exposure likely outweigh risks for white populations, potentially increasing lifespan. Ooh, well then I better get more sun exposure and just forget about the sunscreen. Yeah, so that's a good AI overview of what the study indicates, but that doesn't mean that the study is correct. And it seems weird to say that, but I was intrigued. So I know that MedCram had released a video about this particular study, this UK Biobank study, which has not been published yet, but it's in preprint. So it is accessible to the public. And I decided to look at that, and it's not as great of a study as people are making it out to be. And I don't necessarily fault the researchers. I don't think the researchers did anything wrong. I think that just UV studies in general, or sun studies in general, are much more difficult to control than people think. So with nutrition, there's a lot, like there's certainly issues in nutrition as well when you're talking about long-term studies, but there have been some really good long-term studies in nutrition because of how rigorous they've been about controlling, I should say more so measuring different factors. In UV exposure studies, I looked at this study, and what they did is, like this AI overview said, yes, it was like 400,000 people, and they categorized them into low, medium, and high exposure to UV, so ultraviolet radiation, which comes from the sun, and in this case, from the sun. And so what they showed, and it's true that AI overview says what's correct. So it showed that those with the higher UV exposure or sun exposure had, and they were more specific about UV, but so that's going to be one of the sticking points. They said more UV exposure was linked to reduced mortality, if that's all-cause mortality, cardiovascular mortality, and even cancer mortality, though they did show a slight increase in skin cancer mortality, but other types of cancers were improved, at least associatively. Now, I had a number of problems with this study. I'm not going to regurgitate everything that I went over in my analysis. I'll link that for you. But one of the big issues is that they kept referencing everything to UV, as in UV was associating with these things. And that's technically correct. But can we then jump to UV being the cause of these things? And I'm not talking about just simple correlation. It's not causation, because there are many epidemiological studies that are really well done, as in, they measure a bunch of different factors that could be the real reason for the results that we see. And I've been a big fan of those studies. So I can't, double back and suddenly be like, oh, it's correlation, so therefore it's not, causative, because that's just not fair. However, when you're talking about UV radiation in that study, from what I read, and I read the whole thing, but maybe I missed it mentioned once, they never mention red light or near infrared light or infrared light or whatever you want to call it. And yet, like, red light is one of the major components of sunlight. And we have many studies at this point showing that other forms of light, like red light, have positive effects on the body. And yet we don't have nearly the same evidence indicating that UV, ultraviolet light, is causing, positive effects. There are a few studies that show improvements in like blood pressure and things of that nature, but there's also tons of studies that directly show that UV is extremely harmful, especially at high doses, can cause cancer, lead to death. And I showed some in my analysis, I showed some direct like preclinical evidence indicating that, when you expose certain animals or life forms to UV, they die very quickly when they're highly exposed to UV. Now, of course, it could be dose makes the poison and all that good stuff. But what we don't have is the same thing, as far as I'm aware, in like red light. So this whole study was based on UV associating with reduced mortality. Okay. So in this AI overview actually makes a mistake. It says, suggests that higher ultraviolet exposure from sun or sunbeds. Okay. So the researchers did not specify what sun lamp was. They did mention a sun lamp solarium, which I postulate, I guessed, okay, maybe it is what they're talking about is a tanning bed. But it could be, if you look up the definition for solarium, it could be a sunroom, it can be a tanning bed, and it can be a sun lamp. So which is it? And they didn't define it. So I just went ahead with the assumption that it was tanning beds, and this AI thing seems to think that that's also what it was. And So what I did is I found some other studies that looked at tanning beds and sun exposure. And then we'll be able to tease out the difference between, is it sun exposure or is it the UV itself? Because tanning beds largely provide only UV radiation. They do not provide much, if any, red light. I'm just focusing on red light. But the sun obviously exposes us to more than just UV. It exposes us to red light. So now we'll be able to distinguish between, is it the UV or is it something else in the sun? And lo and behold, the study that looked at both showed that those with the tanning bed, that were using the tanning beds a lot, actually had increased risk of mortality and increased cancer risk. However, those that were exposed to the sun had reduced risk of mortality. So that's exactly in line with that UK Biobank in the sunlight exposure, but it is not the same in terms of UV exposure. So the UK Biobank study, in my opinion, my humble opinion, is conflating UV radiation with red light. I think red light is the actual exposure, the actual mediator of the benefit, and UV is just being tracked. So UV is the one that we're actually tracking, and it's not the UV that's actually causing the benefits. So that leads me back to sunscreen, because then I was curious, does sunscreen block out red light? And the answer is no. So you could safely take sunscreen or use sunscreen, block out what I deem the harmful aspect of sunlight, and still be outside and exposed to and get the benefits of the positives of sunlight, which is red light and infrared light and etc. So that's my take. And I certainly had more critiques of the study, like how they measured sun exposure and a bunch of other things. But I will leave that for my full analysis, which I will link for you. Anyway, that's where I stand with that. If you're watching the video version of this podcast, you're going to see the frame continuously change as I continue to try to escape the sun. I promise I'm not a sunphobe. I'm just getting rather warm, so I'm trying to stay in the shade. I promise I'm not a vampire. Okay, let's get into lithium. So last year, I covered a Nature study that looked at and brought a lot of promise to the idea that lithium could be a molecule that could affect, a molecule that could affect Alzheimer's disease in a pretty significantly positive way. That study looked at humans in a cross-sectional way, as in they looked at human brains of people with Alzheimer's and then determined that their lithium levels were quite low. So then they did some preclinical work, so all in animals, and had an Alzheimer's model, and then they applied lithium to that Alzheimer's model to see if it might have some sort of benefit. The answer was yes, it showed significant benefit. So of course, knowing me, hopefully at this point, you know that I wasn't just going to leave it at that if there was evidence in humans. And lo and behold, I did find a few studies that showed that, clinical studies showing, hey, look, lithium does benefit the brain and helps fight Alzheimer's disease. So that was great news. So then I released this analysis, and then showing that, lithium may be a future avenue by which we can combat and reverse signs of Alzheimer's disease. Okay, fair enough. Now, a Physionic insider, which I pay a lot more attention to the insiders. I'm very involved there. So I check in every day, and a Physionic insider sent me, or made me aware, that there was a new lithium meta-analysis. That meta-analysis indicated or put together all of the studies on lithium and indicated that there was no benefit. And beyond that, They even showed that one of the studies that I had used in my analysis last year was a high risk of bias study, as in they didn't use the appropriate controls, or not all of the appropriate controls. Okay, so that certainly piqued my interest. And again, I said this at the at another point in the podcast. I don't care about being wrong as long as I end up right. And what I mean by that is that I want to get the right information out. So if I have to be wrong to do that, then so be it. That's fine by me. Obviously I want to do a good job, so I don't want to continuously, every analysis I get everything wrong. that would be that would be a gut punch, because that'd be like, okay, you need to really reconsider things. But so anyway, I looked at this meta-analysis to see if I'd gotten something wrong, and I was wholly unimpressed by the analysis for multiple reasons. Again, I'm not going to go through every detail. They did bring up some good points, like this one study that was pretty, high risk of bias, and that was the study that showed the greatest benefit of lithium. So obviously, it's going to lead to some like, oh wow, okay, maybe we got this wrong. So instead of recently, what I've been doing with meta-analyses, and it takes a lot of work, but I've been opening up every study that they include in the meta-analysis. If it's a meta-analysis of like 30 studies, I use a random sample, and I try to get the majority of the studies. So I'll pick like 16 studies out of 30 with a random number generator, and I'll open up those 16 studies and do a deeper analysis on those 16 studies. But anyway, this study was, I think, like 6 studies or 8 studies, something like that. It was 7, I don't know, somewhere in that realm. Not like a huge analysis or anything. So I was able to look at all of them, or all the ones that I could get my hands on, which was most of the studies. And yeah, when I opened up these studies, I was not blown away by how the meta-analysis was conducted. And one of the primary reasons is because they included certain studies, and then for some reason they either didn't find them, or for whatever reason they failed to include other studies that I ended up discovering existed. And these studies actually show a benefit of lithium. So if you have an analysis that's on the cusp of identifying a benefit of lithium, but it doesn't, the end result is there is no benefit of lithium supplementation against Alzheimer's, but you fail to include a few studies that do show a benefit of lithium, then to me that translates to, well, if you had included those studies as well, then you probably would have found an effect. And so that's where I ended up landing. I just didn't think that the meta-analysis was that convincing, and they missed some studies. By their inclusion and exclusion criteria, those studies met the inclusion criteria, and they did not meet the exclusion criteria. So therefore, they should have been included, and for some reason, they weren't. I'm not saying it's for nefarious reasons. I'm just saying that it just wasn't included. Okay, so that being the case, I did have a slightly more muted interpretation, because I do think there's a lot of uncertainty when it comes to lithium. Not that because there are some studies that show that there's no effect. And one of the gripes that I had with this analysis is that they included studies that lasted 8 weeks or 12 weeks. And those studies almost I think universally showed no effect of lithium. But again, like, you're applying 8 weeks of a treatment or 12 weeks of a treatment to a disease that lasts, that starts to appear like a decade earlier, and you expect it to just have an effect. I think that's unreasonable. So to include 2 studies or 3 studies that were such short duration, I think is an unfair way to go about the analysis. And I think they should have done their exclusion criteria to exclude studies that were, less than, let's say, 6 months. But anyway, when you exclude those studies and you just focus on the longer term studies, there are most of those studies showed an effect of lithium. It wasn't like massive, but there was an effect of lithium. In addition, there was like 1 or 2 studies. Clearly, it was more than 7 studies in the overall analysis. Maybe it was like 11. But there were a few long-term studies that also showed there was no effect of lithium. So now we've got a mixture of evidence. I still lean in the direction of favoring lithium, but I think that us going wholeheartedly with lithium and saying, oh, there's undeniable proof, I think is a little premature. Actually, I would say it's quite premature. So that's what I essentially concluded in my reanalysis of lithium, that, look, I'm still in favor, but we definitely need more clarity, and there's definitely some things that we're missing here, and I'd like to see some better research that's going to be done. And then when I reported the dose of lithium that was used, which is one area where I did change my mind, because the initial dose that I had seen in some of the clinical trials was microgram doses. So we're talking about 300 micrograms, which was shown to be effective. So trace doses, all the way up to, I think, like 300 or 600 milligrams of lithium salt. So elemental lithium at 300 micrograms, and then up to like 600 milligrams of lithium salt. So lithium salt being like lithium carbonate, lithium sulfate, lithium gluconate. And that's where I ended the analysis. Okay. And that's where some people jumped down my throat. So I'm going to read some of the comments, and then I will continue discussing this a bit more. So the comments were, TRLD said this: so I need to stop eating my spent batteries. Good one, TRLD, which is also kind of a funny username for YouTube. Well, you probably shouldn't have been consuming spent batteries in the first place, but I see your point. Ed said this: I think you screwed up on this post, Nick. Are you saying that this study in Nature was not a clinical trial? Please amplify, as you are confusing many of us. Okay, so Ed is talking about this Nature study that I initially covered, right? And as you heard me discuss, I said that there was some cross-sectional data in humans, and then the rest of it was all in animals, preclinical models using lithium. So, and never in my initial analysis did I ever claim that this was a clinical trial. Never said that. I covered some clinical trials, but none of them were the Nature paper. And the Nature paper is the one that created all this buzz. So the conclusion that, the Nature paper is somehow a clinical trial, I don't know how people got to that conclusion, because I have never uttered those words in my life. So for clarity, the big Nature paper that came out last year was in no way, shape, or form a clinical trial. It was all preclinical data. Okay, so I just want to make that clear. Now, the next comment, I have to zoom in here real quick. I got some heated pushback. Robert Williams said, this post is very annoying. You are rolling back support for lithium, yet you say there are benefits, but we don't know. Yet you say there are benefits, but we don't know what lithium salt this meta-analysis includes. Okay, I'll respond in just a bit. It was only microdoses of lithium orotate that had the previously proposed benefits. You also mentioned that the range of dosing varies widely from micro to 300 milligrams. Such wide ranges of dosing can't be combined for a sensible analysis. I see no reason to disregard the positive findings of the Harvard study. To be clear, that's the Nature study that I've been talking about. People are fighting for their lives, hanging in on to any positive studies, and don't need to be hit with confusing studies that make no sense. I'm a big fan of yours, but this? Okay, so let me break this down, Robert. First off, Thank you. I appreciate it. I'm always appreciative of anybody who watches my content, cares about anything that I have to say on anything. So I do appreciate it. Now, I'd like to just address some of these, and I did comment under Robert's post, because there are a few errors in this comment. So for one, we do know the salts used in the meta-analysis, and that's actually very specifically why I mentioned only those salts in my analysis. So I said 300 micrograms to, I guess, 300 milligrams. I thought it was 600 milligrams. You can go 300 milligrams of these salts. And the salts that were used were exactly the three that I mentioned: carbonate, sulfate, and gluconate. And so that for sure. Then Robert says, you also mentioned that range of dosing varies widely from micro to 300 milligrams. And then such wide ranges of dosing can't be combined for a sensible analysis. I strongly disagree with that. The reason for that is because some of the studies that used microdoses, so trace doses like micrograms, did find effect. So we can't have it both ways, right? We can't say, oh, well, these aren't sensible doses and we want to find an effect of lithium, but some of the studies that used such tiny doses did find an effect of lithium. So do we include them or do we not include them? I say we include them. If none of those studies, if every single study that used micrograms showed no effect, then you could make the argument of, okay, well, maybe they weren't using a high enough dose, which is perfectly plausible. However, considering there were studies that did find an effect, we can't make that argument, right? So I disagree there. I see no reason to disregard the positive findings of the Harvard study, and also mentioned that microdoses of lithium orotate had the previously proposed benefits. Okay, so this was a continuous critique. I had many people, Robert is not the only one, that mentioned that this Harvard study, the Nature study, in no situation do we take a preclinical study and vault over all the clinical evidence. The hierarchy of evidence, according to the scientific, like every scientific website, every scientific organization, is obviously meta-analysis, the randomized controlled trials, et cetera, et cetera. It creates that pyramid. Now you could haggle a little bit on like a poorly done meta-analysis versus a really well done randomized controlled trial. Then maybe the randomized controlled trial would take over, right? But in no situation, the preclinical data is like near the bottom. In no situation do we ever take a preclinical study and take that over a randomized controlled trial, especially, and probably I'll limit it to not in any sort of actionable terms. Okay. And that has been true for all of my analyses. If I ever cover preclinical data, I'm always going to state like, hey, this is preclinical, or this is early research, or this is suggestive, or, words like that. Because if I start like mixing this evidence hierarchy of like, oh, clinical data, yeah, whatever, they said that, but this preclinical study showed incredible benefits in a mouse, so that should vault over like that. You're getting into really dangerous territory there. So I'll frame it this way. The clinical trials that have used lithium have not used lithium orotate. And that was another critique that I received. People were like, well, why are you even wasting your time looking at lithium trials that use a version of lithium that was not shown to be effective in this Nature study? like lithium carbonate, lithium gluconate, and sulfate. And my response is, well, there's no clinical trials on orotate. So orotate is just like wishes and hopes and dreams at this point. We have one study, a preclinical study, indicating that it may be the superior form of lithium. And I acknowledge that. And I'm not going to say that lithium orotate has no potential, but we're not basing recommendations and we're not basing future movement or future actions based on potential, right? Like if you want to as an individual, that's fine. But me, when I'm communicating to thousands of people, I cannot say, oh yeah, you should be using lithium orotate because of this one Nature preclinical study. That's not how this works. I have to report what the clinical studies say, and I have to point out what weaknesses and what strengths there are. Now, here's where people would argue, and I have a rebuttal for this too. Some people said, well, you should at least mention lithium orotate, and because the lithium salts, the other lithium salts have been shown to be ineffective. Okay. Now, this is also incorrect. Okay. So I just want to be clear here. On multiple fronts, people are like pushing back, but there's multiple lines of evidence that they're incorrect. So the reason why I focused on the salts is not just because the clinical trials use those, but because several studies did show an effect of lithium using those quote unquote outdated or incorrect versions of lithium. So how do we explain that? Multiple clinical trials show benefit of using lithium salts, not lithium orotate. So do we just like ignore that? Do we like close our eyes and just kind of hope they go away? Or do we maybe acknowledge that just because this Nature study found that lithium orotate could potentially be a superior version of lithium doesn't mean that the other forms of lithium have no impact? Can we acknowledge that that's true? And if that's the case, then the actionable steps that we have currently based on the current evidence, the strongest evidence we have is in the lithium salts, not lithium orotate. So while I understand the frustrations, I think that those frustrations are based on a thought process that's ahead of where the evidence actually lies. And I think it's important to communicate that effectively. So I'll communicate it effectively right now. We have multiple trials, human trials, that show lithium salts are effective as lithium against Alzheimer's disease. We have one preclinical study that shows that lithium orotate may be superior to those lithium salts. We have no clinical evidence up to now proving that lithium orotate is superior to those other salts so far. It is possible that in the future, and probably very likely in the future, we will get a clinical study that will look at lithium orotate against Alzheimer's disease. Or even better would be lithium orotate versus lithium carbonate versus some other forms of lithium, other lithium salts against Alzheimer's disease. So we can actually have that comparison across different types. That would be brilliant. But that's where we stand now. So I think that my conclusion, my analysis was correct. And I just don't want to jump the gun to lithium orotate without at least mentioning, hey, we don't have any human evidence of that yet. So if you choose to use lithium orotate, I don't see anything inherently wrong with that, but just know that whatever doses you're using are based off of the lithium salts that are not orotate. Okay. All right. So just wanted to address that because it's just important to me. It just matters when people have this like strong reaction against some of my work. I want to make sure that people are clear. I'm not just willy-nilly just throwing information out there. I've thought this stuff out, and I have arguments to defend my stances on everything, or at the very least, almost everything. So there you have it. All right. The final topic that I'm going to cover in this podcast before we get into some of the housekeeping stuff that I wanted to talk about, and a positive note that I'd like to discuss as well, is vitamin K against cardiovascular disease. This is a topic I've been asked to cover for, I don't know, maybe 9 months now, 10 months, maybe almost a year at this point. And I knew that it was going to be a topic that people were really interested in. So I paid special attention, and I tried to pull together every study that I could find on the outcomes that I defined. Those outcomes are 3. So 1, arterial plaque. So the impact that it has on our vitamin K has on arterial plaque. Number 2, the impact that vitamin K has on calcified plaque. And number 3, on overall cardiovascular health or cardiovascular disease. And so I pulled together, I think, 30 studies. I found a systematic review and a meta-analysis, and I pooled all those studies as well. And overall, I was pretty blown away by how confidently a lot of people on social media discuss vitamin K. Now, before I go on, one of the critiques, which I think is perfectly fair, one of the critiques that was levied against me was that I didn't mention the type of vitamin K. To defend myself a little bit, I did mention it. The type of vitamin K, I actually mentioned it 11 times. I measured it, or I counted in my analysis, because I was like paranoid. Did I really not mention it? But I mentioned it 11 times. To defend the people that said that I didn't mention it, I didn't mention it until later on in the analysis. So should I have mentioned it earlier? Yes. So I'll say it now. Primarily vitamin K2. Primarily vitamin K2 MK7 variant. Okay, so that is the one, MK7, vitamin K2, is the one that on social media so many people have talked about, like it's the thing that's going to stop calcified plaque. It's the thing that's going to reverse plaque. It's the thing that is going to help against cardiovascular disease. And after analyzing these 30 studies, was it 30 studies? No, it's 20 studies. Excuse me. Fake news. 20 studies. I'm getting that confused with another analysis, which is a major one that I'm trying to motivate myself to do. It's on statins, and I have 30 studies put together for that one. I'm hoping to do a full study analysis on that, which is like a multi-hour analysis, opening up all the studies to show people the data. Anyway, it's beside the point. So vitamin K, these 20 studies, after I opened up these 20 studies, went through them, like I said in my analysis, I was really blown away by how confident people are, because when they're talking about vitamin K2, MK7, because the majority of the studies show no effect. Now, I want you, like, if you haven't seen my analysis and you just heard that, would you be shocked? Are you shocked by that? Are you surprised at least by that? Because there are, like, almost every video that I saw online was pointing out, oh, vitamin K is like, you have to take it because it's so good for your arteries. It's so good for cardiovascular health. I've got it on my supplement stack, all these different things. And yet, and even in like conference presentations and whatnot, I will see like isolated studies of vitamin K2 against cardiovascular disease or like calcification of plaque or whatnot. But those same presentations don't mention that there are 6 other studies that show there's no effect. I don't know about you, but like and this was true, I think it was like 2 studies showed an effect for one of the outcomes. I forgot which one. It was either arterial plaque or calcified plaque. And then like 6 studies showed no effect. I mean, at what point do we say like, should I really be focusing on these 2 studies that show an effect while not mentioning that the vast majority of the studies showed no effect? How is that responsible communication? Can somebody explain that to me? That doesn't make sense. So anyway, I tried to find some through line. So I looked at my usual things. I tried to separate things by sex. I tried to look at things by weight, like people who are overweight. I looked at things by diabetes risk or metabolic syndrome in general. And there isn't really a clear through line. And all of them, or almost all of them, like I'll say 80%, if not 90% of the randomized controlled trials used vitamin K2, MK7 that everybody talks about on social media. Oh, that's the version that you need. But what I also did is I looked at vitamin K1. So I looked at vitamin K1, I looked at vitamin K2, I looked at different versions of vitamin K2, with obviously MK7 being the major one. And it's just all over the place. The data is just all over the place. Now, you could argue maybe the dosing wasn't enough. You could argue that the trial length wasn't long enough. The number of participants wasn't enough. That's fine. That's all fair. But my point isn't to say that vitamin K definitely doesn't work. My point is that on social media, we talk about things so clearly and so confidently, and yet there's many studies that show that that is not the case. So I just think that we need to take a step, if not multiple steps back, and communicate that clearly. Like, hey, it's possible that vitamin K2 may work. And that's what I mentioned in my analysis, that it might work for people that are otherwise kind of in an unhealthy state, as in they're dealing with diabetes, they're dealing with metabolic syndrome. Then there were a few studies that showed, and largely those were the studies that showed an effect. Was that universal? No, it wasn't. It's possible that the dose wasn't high enough. I think the dose was up to 300, 400 micrograms, something like that. Don't quote me on exactly that amount, but it's somewhere in that realm. And then a critique that people offered was, well, studies never use the high enough dose to find an effect. Well, then where are we getting this information on social media? Because how can we have presentations where we mention that vitamin K2 is effective against cardiovascular disease, and then we offer doses? And yet there are many other studies that use the same doses and they don't show an effect. Like, there's something we're missing here. There has to be something we're missing here. But the fact that nobody communicates that is just mind-blowing to me. So anyway, yeah, for reversing arterial plaque, there was almost no evidence to indicate that was true. I think the 4 studies or so that looked at it, at least 3 of them showed no effect. The calcified plaque, there was maybe a little bit more evidence, or at least more studies, and still the majority of studies showed no effect. Then I went to cardiovascular health as a whole, and there we can't rely on randomized controlled trials. In those situations, that's where I specifically broke out vitamin K1 from vitamin K2. Vitamin K1 loses its relationship with cardiovascular health, as in improving cardiovascular health, if you are accounting for vegetable intakes. Vitamin K1 is primarily found in vegetables or in greens and whatnot. So when you account for vegetable intake or green intake, then you lose that beneficial relationship between vitamin K1 and cardiovascular health. So most likely what that indicates is that if you eat greens, that is the real benefit, or maybe vitamin K1 has some benefit, but It's through it's at least masked by the fact that you're consuming greens in general. Okay, so that's fine, right? Fine. Now, the one that everybody goes crazy about is vitamin K2. And for that one, it's still kind of noisy. Like the studies weren't as well done, but there's one study that accounted for calcium intake as a proxy for some of the foods that contain vitamin K2. And even when accounting for calcium, although the relationship did weaken, it was still statistically significant. So that indicates to me that most likely there is still a benefit of vitamin K2 independent of other factors. Now, am I really rock solid on that? No, because the studies were weaker. So we're talking about studies that are measuring nutrition at baseline and then not measuring it again over like 15 years or 20 years or whatever. There's other weaknesses as well, like they didn't account for a bunch of different factors. Some of them didn't account for overall nutrition. Some of them don't account for physical activity. Some of them don't. Like there's a bunch of different factors that they just don't account for. So if you mix all the studies together where they do kind of account for each other, you still get a picture where vitamin K2 may have an independent effect at reducing cardiovascular disease risk, which is okay, fine. Like, cool. So that was kind of my conclusion. I was like, look, the randomized controlled trials are like, if you think there's rock solid evidence, somebody lied to you. And if you look at the totality of evidence across 20 studies, including a systematic review, which came to the conclusion that we do not have strong evidence, or we don't have good evidence for vitamin K, and they were primarily looking at vitamin K2, then my conclusion after 20 studies is like, we've got some evidence overall that vitamin K2, MK7 is a benefit. But that evidence is on shaky ground, as in we need better evidence to be really sure. And I think that's a reasonable take, considering that the majority of intervention studies show no effect. So my conclusion that there may still be a benefit with long-term consumption of elevated vitamin K2 is, I think, a pretty bold one, considering that the intervention studies don't show an effect. But again, those intervention studies are focused on arterial plaque, calcified plaque, and then the long-term studies over decades are looking at overall cardiovascular health or cardiovascular disease. So they're slightly different. They're measuring slightly different things. Okay, so the mechanism by which vitamin K is supposed to work, or one of them, at least related to calcification, is one, it has a role in coagulation, which, actually I'll be addressing that in a little bit as well. So in the coagulation cascade, so like different clot formation and stuff like that, which is a normal process that we have to have, then vitamin K is involved in that. The other one is that it allows for what's known as carboxylation. So it's essentially a specific type of tag that's applied to a protein called a matrix GLA protein. I forgot what the GLA it stands for. It's a particular amino acid. I can't remember the exact amino acid, but it's an amino acid. And this carboxyl tag gets applied to it. And that process of adding the carboxyl tag includes vitamin K. So vitamin K leads to more of this activated matrix GLA protein. And this protein binds to the calcified sections, or the calcification molecule called hydroxyapatite, that gets deposited by our cells into our blood vessels, which leads to this calcification. So the matrix GLA protein physically interacts with that so that it inhibits that process. So now we don't get nearly as much calcification, so it protects us from calcification. A quick point here that you should ask yourself, though, is that do you really want to inhibit calcification if the alternative is that you have more soft plaque, which is more related to cardiovascular disease. And that's something people should really be thinking about. But in the end, even though it is true, and I showed multiple lines of evidence that vitamin K does lead to more of this activated, this GLA protein, this matrix GLA protein, MGP, it did not ultimately yield many convincing data that the calcification process itself would be impeded by vitamin K. Okay, so that's my spiel on vitamin K. Now to some comments. Again, some pushback from people. And I'm actually going to be I'm going to be reading my response to one of these comments as well, because I had the time to sit there and think about it as well. So Brian WNC said, I don't like how you don't differentiate K1 versus K2 more strongly in the information presented. The video is unlike you. It's confusing because you're often just saying vitamin K versus specifically distinguishing vitamin K1 and K2, such as at the end where you say vitamin K can increase the risk of internal bleeding. It's only K1 that increases that risk. I'm surprised that you are not more precise with your language in this video. The functional medicine doctors in my area have had incredible success reducing arterial plaque in lots of patients by having people take vitamin K2, magnesium, and nattokinase. Of course, adding high amounts of soluble fiber and digestive resistance starch also helps. I've seen the data from some of these local patients. I've seen people's CAC scores, so that's the coronary artery calcium score, go down after adding these supplements. There is quite a bit of clinical data out there. That's not necessarily standard RCT, so randomized controlled trials, but it's still useful when analyzing the newest edge of available data. Most of your videos are a home run, but as a scientist, I know that you can handle critical feedback. LOL. We all appreciate you. So first of all, Brian, thank you. I do appreciate it. Again, I'm not above critique. Like, that's fine. Critique me as you will, and that was a very polite and just like, here's my argument. Cool. Like I will never have any problems with somebody presenting that kind of argument. I do get a little frustrated when people question my work and then they don't address the data. And Brian, I'm not trying to like specifically single you out, because I get this just in general. People will say, well, I don't agree with you. You didn't do a very good job. And that bothers me. You didn't do a very good job. But then it would bother me a lot less, and it would actually make me like really think about things a lot more if people said, you didn't do a very good job because you missed this, this, and this from the data that you presented, and or here's some additional data. I think that you should address this. That is an argument I cannot fight against, or I can fight against it, but like it would have to be a conversation, like a good faith conversation of, okay, wow, I didn't see that data before. That changes things. I can explain that by, because this study used this or whatever it might be. But at least then we're having a discussion of the data, as opposed to just saying, well, you just didn't do a very good job. And you didn't use very precise language, which, to be fair, in the first half of my analysis, that's true. I should have distinguished between K1 and K2. I was talking primarily about K2 throughout that part. It wasn't until later that I really broke up the two. Okay, but I ended up adding a response, and I ended up saying that, sure, you're right. I'm happy to take feedback so long as the feedback is correct, which it isn't in this case. And considering that you're claiming that this video is unlike my usual work, I'll defend my work against your word. So, number one, both vitamin K1 and vitamin K2 are implicated in the clotting cascade and are a hazard when consumed with blood-related drugs. And this is where I took a little bit of liberty here with Brian, because Brian specifically said that, "I'm surprised that you are not more precise with your language in this video." And Brian conveniently left out some of the precise language that I used in my video, which again just speaks to, like, if we're going to have a discussion, we have to be good faith with one another, and we have to present each other's arguments completely and fairly. So in my video, what my actual argument was, hey, at the end I mentioned, if you are going to be supplementing, if you decide to supplement with vitamin K, K1 or K2, doesn't matter, then you should definitely think about it even more, as in think about not doing it even more if you are on blood clotting medications like warfarin or whatever it might be. And the reason for that is because it, like I said, it's involved in the clotting cascade. And unlike what Brian said, it is not just vitamin K1 that has that warning. In fact, if you go to the NIH website, if you go to Medline, they explicitly say vitamin K1, vitamin K2, vitamin K3. So all forms of vitamin K, because even though they're not exactly integrated in the same steps, they are integrated in this whole clotting cascade, and they can interfere with that process. So it is a risk. So something that, everybody who's supplementing with any form of vitamin K should be aware of. And that's why I mentioned that it's specific to people who are taking these drugs. Okay, so I mentioned that in the video, which Brian left that out. So to say that I'm imprecise with my language, but then mischaracterizing what I actually said is, again, I'm not like saying anything. I'm not saying this was on purpose or anything like that. But I do think that when people come to me and they've got critiques, and it's like well-founded critiques, I get really frustrated with myself when I mess something up. And I immediately try to jump on it and try to correct it, and of course give that person credit. But what I also really think is important is that I defend my work. And when I don't think that a person is being fair about how they're representing my work, it does bother me, because if people just read that comment, then they think that, oh, Nick isn't being precise, or Nick isn't a good source for reputable information. And my integrity and the work that I put out there, I'm constantly trying to improve it, because my integrity just means so much to me, and putting out good information, great information, is of the utmost importance to me. So when somebody points out that I made mistakes, I jump on them like, where? Tell me how, like, where did I make a mistake so I can correct it. But if somebody says, well, you made a mistake and I just feel this way, and then they are mischaracterizing my perspective, I have to defend myself. I just don't consider it right. So, number two, you mentioned functional doctors have had success, and that's fine, but that isn't scientific evidence. Second to that, by your own comment, they used multiple interventions. So remember, by Brian's point, mentioned that they used vitamin K, they used magnesium, and nattokinase, and then later also mentioned soluble fiber and digestive resistant starches. So now we're talking about 3, 4, 5 different things being used at the same time. And let's assume that those people did have arterial plaque reversal. How in the world can we attribute that to vitamin K? The better evidence, the randomized control trials that look at the matter against a placebo group, show no effect. So why would I suddenly take let's say multiple anecdotes, even in a clinical setting, that have no control group, that use 5 different interventions at the same time and then say, aha, vitamin K, that's the thing that worked. That doesn't work. That's not a scientific way to approach the evidence. Number 3, I've seen people's CAC score go down after adding these supplements. Again, this is anecdote. Limitless factors could confound that result. Okay, and then number 4, there's quite a bit of clinical data out there. That's what Brian said. And all I said was just provide some. I provided 20 studies. That's not necessarily standard RCTs. That's what Brian said. Okay, so I provide gold standard evidence, and in addition, look at long-term data as well as a systematic review, actually technically 2. So along the hierarchy of evidence, I've hit all 3 pillars. So that systematic review at the top, randomized controlled trials, and then the epidemiological evidence after that. And of course, you can have a little bit of mixture between them, depending on the quality of each. So I've hit all three pillars. I'm happy to look at more evidence, but you are self-proclaiming that the evidence is not as rigorous, because Brian admitted, which was good, that the clinical evidence is not going to be up to par of the RCTs. So the entire argument is based off of anecdote, clinical settings where multiple interventions are used, and even if there was like the best possible clinical data, none of that is controlled. None of that takes into account like randomization, placebo control, nothing. So it's going to be lower quality evidence regardless of how you slice it. And then I said, again, I appreciate the feedback to improve, which I always do. But I can't just accept feedback without justified pushback if I think and proven that I've done my work properly. And that's really important to me. I feel like I really have to communicate that multiple times over, because it matters so much to me that I'm willing to back down from positions as long as I'm presented with information, data specifically, not information, data that is rigorously controlled, that, where I've missed particular aspects. And in that situation, yes, I will definitely issue corrections, do whatever I need to do. But I just can't have people, and people often do this, they just feel that I've done something wrong, or they've got clinical data, or they know the brother of my aunt, I was going to say brother of my aunt. Well, that would be your uncle then, or yeah, that would be your uncle, or maybe even your dad. I don't know, the lawn care guy of my aunt started taking vitamin K, and his angina, his chest pains went away. Like, okay, I mean, that good, like, I'm glad, but that doesn't prove anything to me. That's not evidence to me. Okay, anyway, .mac48 said, my problem with scientific studies of supplements is that they seem to use the smallest dose possible and then say that it doesn't do anything. Okay, so I kind of addressed that earlier, right? Let's assume that that's true, that the scientific studies, which, by the way, some of the studies that showed an effect use the same dose as some of the studies that showed no effect. Okay, so that's one very important point. So let's assume that the studies don't show an effect. And yet, on social media, we have health influencers that will point to the study that did show an effect and say that's the dose to use. And yet they ignore the other study that used the exact same dose, if not potentially higher, and still say that this one dose is the one that has scientific evidence behind it. Or even worse, in my estimation, is they just make up a number. They just say, okay, 300 micrograms showed some effect. Let's double it, 600. In that situation, you just have a person talking versus studies that show there's no effect. So again, like, it's kind of a risk-benefit situation, but I tend to be pretty conservative. I'm not as conservative as some physicians, where they only focus on drugs, or they only focus on exercise, or they only focus on nutrition, which is fine. And I do as well. But I go just a little bit beyond that. But then there are people that go leaps and bounds beyond that, where they just kind of throw out numbers and they're like, well, my functional medicine guru or whatever, some health influencer said that you actually have to take triple what the studies show, and that's why it's underdose. It's like, based on what evidence? Do they have any pharmacokinetics? Do they have any sort of data to indicate that that's the case? They're just saying it. They're literally just saying it. By the way, omega-3s are not effective at 1 or 4 grams. What's actually effective is 10,000 trillion billion kilograms of omega-3s. Don't ask me for evidence. I tried it on one of my clients and it worked. Like, that's not evidence. That's a scary situation to be telling people that that's what's going to work. So, and also I mean, you may feel different, you listening to this, you may feel different, but my impression is that scientists aren't out there designing studies that they know are going to fail. You understand that a scientist doesn't get funding anymore if they continuously release studies that don't show an effect. And not to mention, they're going to get under more scrutiny for future grants. So I just find it hard to believe that these scientists are like, okay, let's put a year or 2 years worth of work into this vitamin K study, but let's figure out a way for it not to show an effect. Like, what? Who would do that? And not to mention, it's not one group. It's like 10 different research labs. They're all doing it. They're all underdosing. Like, there's a reason why they go for these particular doses. There's preclinical data. There's pharmacokinetic data. There's all kinds of other types of data that indicate that's the dose that you should be using. And then studies, if they see kind of marginal benefits, maybe they'll be like, okay, let's try increasing that for a future investigation. Let's try to increase the sample size. Let's try to do different things. Let's elongate the study. Like, they're always adapting. Like, scientists aren't doing research just to find null results. To me, that just seems, it's just kind of out there. I mean, could it happen? Yeah. But could it happen across the entire scientific field? I don't think so. And again, maybe you feel differently. Okay, William Boquist said, I think in my video, I said, I think you'll find these results are sobering. And William said, good. I'll bookmark this video and watch it again when I'm hammered and have work to do. So yeah, that was a good one. And then I'm gonna rant a little bit longer. Hopefully you'll indulge me. I also get these comments of people that just kind of treat me like I'm a kid, and I don't know, right from wrong, and I'm still stuck in the establishment, and I don't have the world experience to be able to speak on some of these topics, and like, fine, whatever, but. There were a few comments. One of them I find really funny because of who sent it. But one comment said, BD Cochran 01. This was perfectly fine comment, but just kind of in that same vein, which I get a lot of these. I'm old enough to be your grandfather. Therefore, I relate some things to bear in mind. One, everything that I learned in college 60 years ago has been proven wrong, superseded, or has become nuanced. Actually, that sounds pretty good. That sounds like progress to me, especially the last one. If it's become nuanced, I love that. Two, if you condition yourself to question your assumptions and your indoctrination, you will be ahead in life before most people. Okay, I think people don't understand like what goes into a PhD. I mean, the whole thing is just questions, right? Questions, and then you go find the answer. And they give you money, they give you resources, and then you get some guidance from a PI, your mentor, and they tell you, okay, go, try the experiments, Try to figure out the answer. 3, do your own research. In the old days, I had to go to the medical library and struggle to find information. Now you can use your home computer. That's true. That's definitely true. I mean, the internet has opened up so much, and I completely agree with that. And number 4, always value facts over the truth. The first is objective, and the second option is subjective. Honestly, I'd probably have to think about that one some more. I don't fully understand that one. And I did end up commenting. I said, I appreciate the comment, but I'm very confused as to how this relates to the topic. This was under my vitamin K analysis. And then somebody else responded, which I'll get to, but like, do your own research. This is something that's kind of become a mainstay for a lot of people. Just do your own research. But if I can harken back real quick to somebody else who commented in one of the previous analyses that we went over for glycine, Sabrina. Remember how Sabrina said, I am truly confused. I thought glycine was an anti-cancer, anti-aging, antioxidant. And then she goes on and so forth. But she says, the more I, quote unquote, educate myself, the more I feel that I have no idea what's going on. Okay. So that's where I think this, this kind of, I don't know what to call it, but this almost anti-expertise kind of mentality of, well, I can't trust other people. I can't trust experts in a field because, whatever it might be, because one day they say one thing or another day they say something else, or maybe the establishment is compromised or whatever it might be. I don't know. It doesn't really matter. The point being that we can't trust experts. Like we're kind of getting into this world of like, we just have to educate ourselves. We just have to do it ourselves. We have to do our own research. And I gotta be honest with you, how are you going to do your own research if you don't know how to read the controls on a Western blot, or if you don't understand how HPLC is done, or how mass spectrometry is done, or like, how are you going to, you don't know how the experiments are done that gave you the data that you are then having to analyze, not to mention then you have to run it through statistics and understand how the statistics work. Like, that takes work. It's like, during my PhD, I didn't just like twiddle my thumbs. Like, I was educated obviously on the general stuff, right? I went through all the body systems. I went from the molecular level up to the whole physiological level, and it was grueling. But what I was also taught for 3/4 of my education was about the experiments. We had to learn how they worked. We had to understand how to piece together experiments to get a particular result, because sometimes you have to do multiple experiments just to get a result. We were given questions and then asked, okay, now you have to design an experiment based off of this. We want to know the answer to this. Like, this is the question, this is the scenario. Now you design the experiments to allow us to do that. And this was in neuroscience, this was in cancer research, this was in gastroenterology. Like, we did everything all the way across. And that's our job. Like, that's what PhDs do. They analyze research. They do research. They actually physically sit there and do research. They think about it. They plan it. They pipette. They do the actual experiments. They put together like actual experimental methods. And then they get the output, right? And then they have to do an analysis on the output. So they have to run statistics, and then they have to sit there and think about what that output actually means. And they have to then broaden that to the overall context of the entire paper that they want to publish. So to me, like, do your own research I think it's pretty treacherous Because if you have no concept of how any of that stuff works, like do your own research is like reading Sanskrit. Like I don't know how to read Sanskrit, so I would just be like, I don't know what I'm looking at. I mean, is age going to make a difference in that? No. Is anything going to make a difference other than just experience, just having been exposed and being taught by somebody who knows more than you do on the topic? That's what you have to do. So yeah, this do your own research thing, I've heard it a lot, and I've definitely heard it against me, for sure, where people have claimed their age. I'm this many years old. You're young. You don't understand. And, that's fine. Like, I think in life, I think that's a really good point. I'm relatively young. And as a result, I have less experience than many other people that may be 20 years my senior. Cool. And I completely acknowledge that. I'm not here to be delusional or anything like that. But I think when it comes to science, at the very least, analyzing studies, I'm not going to say I'm the best or anything like that. And I still have plenty of work to do, and I will always continue to work at it. But I would say in that topic, I have more experience than a lot of people, especially people that don't have a PhD, because that is what a PhD is. On the other hand, if you talk to me about people that study microglial damage after post-traumatic brain disorder, whatever, I'm just making something up, then those people would have more experience than I do, even if they're, let's say, 28 years old, because they've had maybe 2, 3, 5 years of research experience in that area, right? So experience is not just based on the overall breadth of experience of just being alive. It's also based on how you focus your attention. What do you focus your attention on? So again, this do your own research, I don't know. I think it's a dangerous road to go down. But then again, I also don't want people to feel unempowered. I do want people to feel empowered to do a little bit of background reading on their own, and to push their doctors, and to push me, and push other people that are relating this information, because you do want to test, and you want to ask questions, and you want to be curious. And it goes back to one of my previous points of I do love engaging with people that are curious and want to know more, and because that's how I am too when it comes to my field. So yeah, it's a delicate balance. But anyway, thank you for the comment, BD. I appreciate it. Now, like I said I appreciate the comment, but I'm very confused at how this relates to the topic. Socrates had something to say, which I find very funny. Socrates, a very famous philosopher, around the same time, I think he was the tutor of Plato, if I remember correctly. So Socrates said, you proved his point. I'm confused how you're confused. They're talking about how to take in information and not become dogmatic, but to stay open and use discernment, and to rely on facts, not bias. And you don't know how that relates to interpreting scientific data, which is what you present every week. Yeah, again, it's kind of the same argument, right? This idea that we're becoming dogmatic and whatnot, and some people are, for sure. And then I got others like, who do you work for? And I've been compromised by the industry. I've been compromised by big, I don't know who. I don't know. I mean, my conclusion again for this analysis was vitamin K2 probably works. I'm leaning towards it working. Is it going to have a dramatic effect? Probably not. And the evidence is shaky, and we need more evidence. So if that makes me dogmatic after presenting my evidence, again, I just want people to just present data, That's really all I really care about. So I think I've said it enough. I won't go down that road again. Okay. I want to get into some housekeeping. I keep that till the end because I know people aren't always that interested in it. But I want to leave things on some positive notes. I get a lot of critique, but I also get a lot of encouragement. And I deeply, deeply appreciate that. It really does mean a lot to me. So, Physionic it definitely doesn't grow very quickly. It's not a channel that's like exploding or anything along those lines. And I don't really care. I don't care if it does or if it doesn't. Would it be nice to have like huge growth? Of course, like who doesn't want that? But I also don't want it to be, get to a point where it's unmanageable. And I do want to keep Physionic small, just me. And it's fun, and that's important, and it helps people. I get a lot of comments and a lot of messages from people saying how much my work has helped them. And I mean, that means the world to me, honestly. It's just like, it's very, very fulfilling in that regard. And it motivates me further. Again, not that I ever needed extra motivation, but it motivates me further to continue to release intellectually honest information, which again means that sometimes I have to own up if I get something incorrect and correct it. And on the other hand, also to defend myself whenever I think that I've done a good job. So yeah, it's been slow going, but it's growing. And I'm always incredibly appreciative of the fact that I have even a small number of people that care about the work that I put out there. And I get comments, I get emails, and I get messages every day. And I can't keep up with all of it, but I just want you to know that if you've ever sent me a message or a comment or anything like that, even if I haven't necessarily read it, I just want you to know I deeply do appreciate it. It means the world to me. Beyond that, and just the fact that I get to do this independent of any sponsorships. I think like 2 years ago, I was really wrestling with the idea because I've received at least 300 sponsorship requests. On my website, I have, for the messaging, before people send me an email, I have a note that says, do not contact me if you are trying to pitch me a CEO to be on Physionic, if you're trying to pitch me some researchers that's selling their supplement or whatever to be on Physionic, if you are trying to sell your new magnesium glyphinate, I don't know, I'm just making something up, 3,000, I don't care. Just don't even bother contacting me. And I've still been contacted hundreds of times from people trying to get me to like for them to sponsor a segment on Physionic. And I remember about 2 years ago, I asked you how you would see me if I did take sponsorships. So if I did like sponsored segments and whatnot. And honestly, I think the majority of people said that they didn't care. It wouldn't have bothered them. And there was a small number of people, I'd say maybe 20%, 30% maybe, that said it would probably shift their perspective. And of course, it's a bias sample because people that are going to click on the video, they're going to offer their opinion. The people that are going to say, oh, it wouldn't bother me, that's probably because they already trust me. But what I'm also trying to do is make sure that the perception of having outside influences is something that I'm really trying to push away as well. So even though I could have done some sponsorships with some pretty big brands, I just chose not to. And even though the majority of people were saying it probably wouldn't change their perspective. And it wasn't actually about the opinions of those people that leaned me towards not doing sponsorships. It was actually the people that I haven't reached yet. I want to be able to be in a position where I just say, oh, I have no one is dictating anything except for me and the I guess called the crowdsourcing from the insiders. So to me, it was really important that I keep myself sponsorship free, and I will continue to do that for as long as I can. And the fact that I get to do Physionic sponsorship free, and I've also stepped back from consulting as well, not completely, but by a large part. And I get to do what I love, which is just analyze research to the end of days. Just constantly be reading research and to have fun putting these videos together and the articles and like all that stuff. And if you're not familiar, I also release multiple articles per week that release on my email list, the free Physionic community as well. I also post them on LinkedIn and a bunch of other places. So the fact that I get to do that is just like, it's incredible. And again, I always end these podcasts. I always say thank you because it really does mean a lot to me. I also do these podcasts only every 6 months. So I want to remind you that I'm continuously thankful. I just wanted to point that out. Okay, so I did want to leave here with a few more things. One is even though the comment section can be a place that's just like full of nonsense, I've also had the pleasure of having some really funny people comment. You heard some of them, right? Like the Berberine joke that we talked about earlier, or what was the other one? I forgot. Anyway, the sobering one about vitamin K. But I also have some really great engagements with people that comment. And sometimes people will say, I've never commented before, but I needed to say this thing. And so I try to, like, obviously I miss hundreds and hundreds of comments, but I try to respond to those kinds of comments because I want people to feel like Physionic is a place where they can actually speak and not feel like dumb questions. There are no dumb questions. Like, technically there are dumb questions. Like if I say, is this phone cover, like, is this screen black? And it's clearly black. I guess that would be a dumb question. But in general, when it comes to scientific questions related to like biology, physiology, nutrition, and whatnot, it can be a really basic question. But just because it's a basic question doesn't make it a dumb question. So anyway, this all to say, I'm kind of talking in circles here, but this all to say, I had a lovely exchange with Michael Johnson that I wanted to read to you. Michael Johnson said, I've been trying to better my health for a number of years now. I'm 36 and I have agoraphobia as well as fibromyalgia. I'm not the most intelligent person in the sense that I find it genuinely difficult to differentiate fact from fiction due to so many quote unquote experts online. And I'm also not very successful academically, kicked out of school at age 15. There's no such information out there that I find there is so much information out there that I find simply overwhelming. I'm also not the most well-off person, so finding decent quality supplements are hard for me. I try to focus on diet as well as exercise naturally. I suppose what I'm asking is, how would someone as bewildered and overwhelmed by such information navigate this minefield of a subject that is health and nutrition? Apologies for such a long message. Again, that's why I had this preamble, because you understand, like a person that's dealing with agoraphobia, fibromyalgia, and like many other people have commented about other issues that they have, and to put that out on the internet, and I think it takes a certain level of bravery, and I really, anytime I see a comment like that, I do try to engage because it means a lot to me. going back to what I said at the beginning, but also I just want to recognize, and I really want to tell people that, like, I hear you, and even though there aren't a ton of resources out there, there are people that are trying to do the right thing. And I've engaged with them in the past, and I will continue to engage with them in the future. And I'll always try to highlight people that I think are doing a great job, which I may actually come back to that point in just a little bit. But let me get to my response. Michael, if this is your barometer for your intelligence, quote, in the sense that I find it genuinely difficult to differentiate fact from fiction due to so many quote unquote experts online, then we are all morons. Just by the way that you write, I can tell that you're far more intelligent than you give yourself credit. As for navigating an information minefield, that's a topic that I'm still wrestling with. I don't have a satisfactory answer. I used to, but it's had a few holes blown through it. In my field, it's easy to differentiate because I know as much as they do. However, in other fields, I also have trouble. I tend to just rely on the most boring sources, so textbooks, releases by research bodies like universities and the like. Or I have a few people that I trust outside of my field, like my dad in physics. He has a PhD in physics and a master's in mechanical engineering, so I ask him on physics concepts. It's not easy, and you are not in any way less intelligent for not having figured it out. And then his response was, thank you for your response. I hope that the term quote unquote experts in quotation marks wasn't taken as an insult to yourself, as I do trust you. Thank you, Michael. No, it was not. I'm sure you're aware of so many people online claiming to be someone that they're not. I do not believe that is the case for you. Thank you. I'm just extremely exhausted with everything, and I think I worded my comment in frustration. I just want you to know that I appreciate all the work, and I hope that we can all find simpler answers to some of life's toughest questions. Thank you for replying to my comment. It means a lot to me. Yeah, so I wanted to highlight this because the bigger question that Michael's asking about this, I'm realizing I'm getting sunburnt over here. Joy, oh joy. I tried to escape the sun, couldn't do it. The sun hath defeated me. Yeah, I think the bigger point here, though, and it's true, like I used to have answers, right, for like who you can trust, who you can't trust when it comes to this field of like health and nutrition and exercise and whatnot, which are kind of intermingled, medicine. And it's become more difficult simply because I think in the past, maybe 5 years ago, I would have said, well, the people that actually provide citations, the ones that actually discuss science, that actually, go into studies, like actually say, hey, there's this study and this is what it says, is a pretty good barometer, at least an initial marker that it might be someone that you could listen to. But nowadays, what I'm finding is that there's a lot of, I'll just go ahead and say it, charlatans that use studies and they just pick out little phrases from those studies and then, or small concepts from those studies, or completely butcher the study. Or they'll just, they use one study and then ignore all the rest of the literature. And they make entire videos about it, where it's like a person holding a walnut and it's like over some like green drink or whatever it might be. And it's like scientists have broken open the reality of heart health or something like that. And it has to do with this. And it's just like, I don't know, some like obscure study that's just like out of Russia in 1983 or something like that, where they gave walnuts to Labrador dogs or something like that. And they, I don't know, it's just like, you get my point. It's just like completely obscure and it's just so far out there, but they're technically following what I used to say, right? Like they're using a study They're flashing the title of the study. They have references. Maybe they have references in the description. But that doesn't actually mean that the study says what they say, or in the context of the literature, that that's actually an appropriate overall conclusion. And not to mention, it's like short-term memory loss, right? Like they say one thing on 1 week, which it goes back to, one of the major complaints I was talking about earlier. And then the next week, they're talking about something completely different that also does the same thing. But they never release a video that says like, hey, by the way, I know that I said that this was the biggest thing, and now I'm saying this is the biggest thing. The reality is that, they both contribute such a high amount, such a great amount that and they start trying to apply context, like what they said. They just blast forward. The third week, they're like, this is the best thing in the world. And you do have to take a few pages out of their book, because if you're going to fight that fight of like trying to get good information out there, you do have to create kind of like explosive narratives and stuff. But you're always, if you are really trying to put out good scientific information, you're always going to be constrained by what the data actually says. And that's always important. And there's a Reddit post. I'm on Reddit a good amount. I just like to peruse. I like to talk with people that are also in kind of scientific nutrition and that are in the subreddits and different biohacking and whatnot. And plus, there's sometimes really good topics, and there's actually some really good discussion there sometimes. So sometimes being the operative word there. But there's this one person that posted my vitamin K video and analysis. And there's this one person that commented, and I actually really liked their comment. It was largely negative against me, but what I really liked about their comment was that they said, because I responded, they said, look, I think that your, like the titles and the thumbnails are really like, they seem like they're going to be a really exciting concept. And then I click on the video and I'm going through the video and I get bored because it's not as exciting as I thought it was going to be. And I love that, because that's exactly what I'm trying to do. I'm trying to get the right people. I'm trying to attract people, right? So I'm using the similar systems that, people that I don't think are trying to do the right thing. So I'll take like the enticing title and the enticing thumbnail, which of course still have to be factually accurate. Like I can't just, make a video about cancer and then the whole video is about cardiovascular disease. But it has to be accurate. And there's so much exciting information out in the scientific literature. It's just how you frame it. That's important. So the fact that they were enticed to click on it, love that. Because hopefully it took a view from someone else that may be covering that same study, but doing potentially a poor job. But the second thing is that they were bored. I mean, in my YouTube analytics and whatnot, it shows that people actually stick around for quite a lot. But the fact that this person was describing it as boring, I think is kind of a point of pride. I'm not saying that I want to like bore people's pants off or anything like that, but their like head falls off because they're so bored out of their mind. But I don't want to come off as like just another person that's just like throwing BS at you. So once you click on the video, to me, I have leeway to be like, look, I'm going to show you some really exciting stuff that I think is exciting. This is what the data shows. And I'm going to tell you this story that's related through the data. And I think that is really fun and really exciting. And I don't want people walking away thinking that like chia seeds are going to cure their cancer, because they're not, which is like how the follow through for a lot of other channels and a lot of other kind of the health influencer world that I don't really like very much. They have that through line of like, I'm going to blow your mind by focusing on this teeny tiny thing and not expand outwards to give you a clear picture of what the data actually shows. So I don't know. It's navigating a minefield. But going back to Michael's comment, just in general, it's I have not figured it out. I thought that I did, like I said, and now it's become trickier because now you have everybody that's just relying on studies, but that doesn't actually necessarily mean that they are presenting those studies correctly, which ultimately leads us back to square one, right? Now we don't know. So if you have any input, any advice, I'd be happy to hear. I'd like to hear, and maybe one day I can get a guide out of like this kind of step-by-step process. I have thought about doing that in the past, and I've thought about reaching out to some of the creators that I really admire and seeing if we can maybe put our heads together and see if we can come up with some sort of like step-by-step guide. It's not going to be perfect, obviously, but some sort of step-by-step guide that people could just have for free that would help people navigate, okay, I'm watching this video. Here's my 3 steps I need to think about. Do they fulfill step 1? Do they fulfill step 2? Do they fulfill step 3? And that'll give at least some guidance and hopefully some ability to navigate, because if we rely on things like the centrifuge, or I know Gilles Carvalho at Nutrition Made Simple has some stuff where he debunks particular influencers as well. If we rely on that, I mean, the speed at which people can release BS is a million times faster than we can sit there and fact check and make sure we're being polite and make sure we're being, appropriately giving credit where it's due, and then, correcting where it's due. It's going to be impossible. So we're going to have some sort of system to try to tease out some of those. Anyway, so I just wanted to end things on a positive note. I've started upping my Instagram game. That's been going surprisingly well. All I do is just turn on a camera and just talk about stuff in far less long-winded format than I did in this podcast. But that's been going well, surprisingly. I've been pleasantly surprised. I'm trying to just have fun. Just try to branch out and see what other avenues I can use to kind of spread the scientific nerddom, in a manner of speaking. One last thing, I got a dog. Back away. Some bumblebee or something was attacking me ferociously. I got a dog. Her name is Olive. I will post a picture if you're interested. And that's my non-scientific, non-physionic news. It's been a joy so far. Definitely enjoying life with Olive. What else? I think that's about it. Again, if you're ever so inclined, then you can support me by joining the Physionic Insiders. But to be honest with you, do not join the Physionic Insiders just to support me. I take extreme pride in the amount of work that I put into the Insiders. You get podcasts which are far more succinct than what I have here. They're just information. You get articles, weekly articles, multiple weekly articles. You get a private email list. You get no ads on any videos, on any articles, nothing. So everything gets delivered to your email inbox. You get live sessions with me. What else do you get? I designed a Physionic AI. It's not like the best thing in the world or anything, but I taught it based on all of my work, so it answers based off of my work. And you get a bunch of other things as well, like 1 paragraph summaries with the main key takeaways that you should have. Oh, master supplement list that I built. I'm very excited about that. I think people are really taking advantage of that. It goes into the supplement. It goes into the outcome of interest. It goes into the amount of impact that I think that supplement will have, and then the dosing, obviously, and then the different brands that I think are good brands. So, and then there's a few other benefits of being an insider. But anyway, you don't feel any pressure to join. But for those insiders that are insiders, people have messaged me that they're quite happy with the quality of the work that's there, which I'm deeply appreciative of. Again, I take a lot of pride in how much work I put into it, so it means a lot to me. Anyway, Physionic insider or not, I deeply appreciate you being here. I know that this was a bit of like, getting into some of the specifics of different comments and stuff like that. And I think that I'm trying not to be quite as solely focused on just analysis and whatnot, but also trying to hear and understand where people are coming from and try to answer questions wherever I can. So hopefully it was of at least some benefit. And if you're asleep, then nighty night. I hope you sleep well. Thanks again, and until next time, maybe in 6 months, maybe in a year, who knows. Till next time, see ya.